So this is a little tricky to remember, but you have to. So this is about gestational trophoblastic neoplasm. So now let's start discussing abortions. Very, very important topic. First of all, the definition of abortion is any delivery before 20 weeks or if the weight is less than 500 grams. So this is what is the definition. This is before the period of viability. So this is what is defined as abortion before viability. So less than 20 weeks or less than 500 grams. Here the approach remains very, very simple. You have to look at the os and then decide. Without that you can't say. Alright, so that's what you have to remember. First we look at the internal os. So vowels stick together. So you want to remember os open means the diagnosis has to start with a vowel. Os closed matlab the diagnosis shouldn't start with a vowel. So this is what makes it very, very easy then. So now look at the supporting features. Os open with bleeding and pain and the uterus is smaller than the expected POG and ultrasound reveals retained products of conception. What does this mean? It means half has been done. Incomplete abortion. If the os is open, the bleeding and pain is there and uterus is equal to POG, what does ultrasound show? The ultrasound shows that there is fetus but no fetal cardiac activity. So can this be salvaged now? Can't be salvaged. No fetal cardiac activity means intrauterine fetal demise. So what does this mean? This is inevitable. You can't control it. So this is what is inevitable abortion. Right? So os open, two vowels. Look at the next one. Os is closed, bleeding has stopped, uterus is smaller and upon ultrasound what do we see? Empty. Everything is finished, over. So this is what is a complete abortion. Os closed, spotting and pain is there and uterus is equal to POG and look at this. This is the only type where fetal cardiac activity is present. So can we save this? Yes. So this is the one which is very, very important, threatened abortion. So threatened abortion is the only one we can save. What are you going to advise? You have to advise strict bed rest to the patient and you have to advise progesterone. So progesterone will support the pregnancy for longer. So progesterone suppositories are usually given or basically vaginal insertion. So progesterone pessaries are what are recommended to the patient. So this is what is threatened abortion. Os is closed, spotting and pain is plus minus. So this is the only type where patient may not even come to you. So this is where you do the ultrasound and you detect, oh, there is no fetal cardiac activity. So this is what is missed abortion. This is the only type where patient's presentation will be plus minus. Upon ultrasound diagnosis, there are two terms. On ultrasound, now the recent guidelines say we don't use these terms like missed abortion. What we call is early pregnancy failure. These numbers are very important. Remember two criteria. First criteria is a GSAC more than 25 mm, means a very big GSAC, but still no fetal pole has appeared. So this is what was previously called as a blighted ovum. But now we call it as early pregnancy failure. And the other criteria is CRL. The crown rump length of the fetus is more than 7 mm, but still no fetal heart rate has come. So this is what was previously called as missed abortion. But now both of these are criteria of early pregnancy failure. So remember both of these numbers, both of these terms, okay? Let's talk a little bit about preterm labor. So preterm labor is where you have established contractions with more than 2 centimeter dilatation. So this is what is the definition of a preterm labor. The definition for the contractions will be more than equal to 4 contractions every 20 minutes. All right. So this is what the number says, more than 4 contractions every 20 minutes and any dilatation more than 2 centimeters. So essentially you can remember more than equal to 3 centimeter dilatation. All right. So that is what is the number for preterm labor recent update. So more than equal. So you can remember 2, 3 and 4. Right. So more than equal to 3 centimeter dilatation or more than 2, however you want to remember, every 20 minutes more than equal to 4 contractions. So 2, 3, 4, this way you can remember preterm labor definition. How do you manage it? Depends on the POG. So if less than 34 weeks, what is absolutely mandatory are steroids. We will look at what steroids are given, but this is for the lung maturity, very, very important. Group B strep prophylaxis should be given, which is penicillin or ampicillin, tocolytic. Now, the tocolytic of choice that we use in India is nifedipine. Apart from this, indomethacin can also be used, but the thing with indomethacin is don't use it beyond 32 weeks, right? So this is only used less than 32 weeks because otherwise it may cause the premature closure of ductus arteriosus leading to PH. This is what we'll write later on. And we also have specific tocolytics like atosiban. What is atosiban? It is your oxytocin receptor antagonist, right? So that is what is atosiban. It can be used in patients who have heart diseases, right? So that is the niche indication for atosiban. Hasn't been tested, can be asked. All right. So this is what are your tocolytics. So these three are given if less than 34 weeks. Less than 32 weeks, we also have to add magnesium sulfate because it is a neuroprotective. So with this, you need to remember three things where you will study MgSO4 in all 19 subjects. One is torsades de pointes, drug of choice. Second is as a neuroprotective in pregnancies with preterm labor less than 32 weeks. And third is eclampsia management that we will study. Okay. More than 34 weeks, what you want to remember is you will only give GBS prophylaxis. You are not going to give tocolytic. You are not going to give magnesium sulfate. What about steroids? A single dose of steroids can be given, right? So steroids I'm going to write as plus minus, meaning you will not wait for 24 hours to complete the entire course because you expect lung maturity to be present, but a single dose can be given just for the sake of it. Induce in PPROM. So this is very, very important that when will you try and accelerate this? That is when you have preterm rupture of membrane as well, and you have associated chorioamnionitis or abruption, or there is fetal distress. So when are you actually going to augment this labor or this process of labor, preterm labor, which has started in rupture of membrane, chorioamnionitis, abruption, fetal distress? Very, very important. Amniotic fluid. So how to confirm that it's indeed amniotic fluid? For that, there are few tests. So you have furning which is present. You have a nitrazine blue test where you can check the alkaline nature, and Nile blue sulfatase test. This we also studied in pediatrics. So this will show you the fetal lung cells or the fetal skin cells, right? So this also confirms the presence of amniotic fluid. You can also see this fetal fibronectin. Alright, so all of these are to confirm the presence of amniotic fluid. So this is about abortions, preterm labor. Extremely important. FMT OBGY overlap is MTP. So we are learning MTP 2021 guidelines. You had around 2-3 questions from this one page in the last NEET exam, right? So this is very, very important. So MTP 2021 says that we can do MTP at any point of time. So less than 20 weeks, 20 to 24, more than 24 weeks. Before that, see the indications. First, therapeutic. If the mother's life is endangered, therapeutic indication. If there is a fetal anomaly, eugenic indication. Humanitarian indications of MTP include the pregnancy is a result of rape or incest, or it's a minor girl, mentally ill, or marital status change, meaning you are undergoing separation after the pregnancy was found out, or social meaning contraceptive failure. So up till 20 weeks, any indication is fine, right? So I'm going to write T, E, H or S, right? So either of these less than 20 weeks, not a problem, and you need consent of only one doctor. 20 to 24, now things become a little riskier, right? So the only thing which we will not allow now is social. You can't turn up at 20 weeks or more and say that it was contraceptive failure and I don't want this child. So what were you doing for 20 weeks? So now this is not valid. So this is where 3 indications are valid. T, E, N, H, and now you need consent of 2 doctors before doing this. More than 24 weeks, only 2 indications, because this is very risky. So we'll only do it either it is therapeutic for the mother's health or there is a gross fetal anomaly that has been found out. So these are the only 2 indications, and this is where you need consent of a medical board, which will consist of 3 doctors. Obviously, 3 doctors who are involved in all of this. One will be a radiologist, one will be an OBGYN, and one will be a pediatrician, right? Why would a lawyer be present? So this was asked in NEET exam and the 4th option was a lawyer. So obviously not. So this is where you have to remember about MTP. What is the age of consent? More than 18 years. And consent of husband? No. Whoever's body, that person's consent. Who can do MTP? Any OBGYN obviously, any MBBS or a registered medical practitioner who has done 6-month internship or 1-year house job or assisted more than or equal to 25 cases of MTP. So these can do MTP. What do you see here? Very, very important image-based question. So always look out for these two side thingies here, okay? When you see these two side thingies here, this is what is MVA, manual vacuum aspirator. If you see only one, then that is what we call as a menstrual regulation syringe. Okay, so in a menstrual regulation syringe, you will only see one siphon here that is frequently used in, menorrhagia cases, etc. So there's only one siphon there, whereas if you see two, that's your MVA. Manual vacuum aspirator, the advantage is this does not need electricity. So this is what can be used, in peripheral healthcare centers. Okay, so this is what doesn't require electricity. 3 numbers for you, everything starting with a 6. So the volume of this syringe is 60 ml. When you pull this plunger, the pressure it can generate 660 mmHg. And this can be used for MTP from 6 to 12 weeks period of gestation. So 3 6 number, 60, 660, 6 to 12 weeks. So now let's learn more about MTP. So when we talk about MTP methods in the first trimester, Indian guidelines used to say that there are different methods till 7 weeks and then different methods till 9 weeks. So now the recent WHO update says that all medical MTP, same method up till 9 weeks can be followed. So what you have to remember here, that you are going to start off with 200 mg misoprostol or mifepristone. Remember, alphabetical order, right? So 200 mg mifepristone, and then 48 hours later, you are going to give 400 was the older number. Previous guidelines said that till 7 weeks give 400 and then 7 to 9 give 800. Now the recent update says everybody is going to get 800 microgram misoprostol. Alright, so 2 numbers for you, 200 and 800, alphabetical order, you will not mess it up. Right, so this is what is the medical MTP permitted up till 9 weeks. What you also want to remember, that mifepristone is what we call as RU486, right? So this can also be mentioned. What about other methods in the first trimester? Apart from that, you can do suction and evacuation. So suction and evacuation, remember, not dilatation and curettage. As we said, curettage not to be done, Asherman syndrome. So suction and evacuation can be done up till 12 weeks. Okay, so this is first trimester. What about second trimester MTP? Extremely important. So here also we can do the medical management. This is where you will give misoprostol. This misoprostol, that is PGE1, 400 microgram is to be given 3 to 4 doses. All right, so you want to remember 3 hourly, or some people say 4 hourly. So 3 to 4 hourly, and a maximum of, again, variable things, so maximum of 4 to 5 doses. All right, so that's what you want to remember. Misoprostol 400 microgram, 3 hourly, 4 to 5 doses. So 3, 4, 5. That way you can remember this. Okay. So this is about the medical aspect. Apart from this, you can also do dilatation and evacuation here. So this is not DNC, this is DNE. This is what uses ovum forceps, right? So this is where you can evacuate using ovum forceps, which I'll show you in the last part of this video. 2 things just for MCQ purposes you may be asked. So this is where you can do intra-amniotic injection of hyperosmotic saline or extra amniotic, E for E, extra amniotic ethacridine. Okay, so E and E, this is what can be asked to you. So these are the different methods of MTP that can be tested. So first, all of these are very, very important points. Okay, so medical management can numbers 2 and 8, second trimester 4, 3, 4, 5, very important. Remember, intra-amniotic saline, extra-amniotic ethacridine. All of these are extremely important topics. Even more important is recurrent pregnancy loss. So recurrent pregnancy loss, the definition is 3 or more consecutive abortions. And what you have to remember here, that the evaluation, begin evaluation after 2 or more. So begin workup at 2 or more, but the definition of recurrent pregnancy loss requires 3 or more consecutive failures of pregnancy. Okay, so this is what is the number. The most common cause of RPL, recurrent pregnancy losses, in the first trimester are chromosomal abnormalities as a group, where you have aneuploidies. In the second trimester, you have structural anomalies as a group. But if asked what is the single most common cause, single most common cause becomes APLA. Alright, so APLA is the single most common cause of recurrent pregnancy loss, but as a group, first trimester, chromosomal anomalies and structural anomalies in the second trimester. Structural anomalies, as we said, were Mullerian anomalies that we already studied, and cervical incompetence, which I'll be teaching you now. Alright, so these are your one-liners which are not very commonly asked. What is commonly asked is how will you evaluate? So you want to remember, you will not do torch. Torch is not a cause. Infections do not cause recurrent pregnancy losses. Okay, so you will be doing a TVS for structural anomalies. Hypothyroidism is a very important cause. Karyotyping for chromosomal anomalies, and APLA workup. So these are the workups you'll do. Remember, no torch. Let's talk about APLA. So this is the Sydney/Sapporo criteria of APLA. So you can be asked this. So Sydney/Sapporo. Clinical and lab criteria. So clinical criteria, either you have history of vascular thrombosis, which would be venous like DVT, or arterial like stroke. Pregnancy morbidity, a quick way to remember this is remember 3 into 1. What does that mean? Any one failure which is happening in the third trimester. So any preterm birth at less than 34 weeks, either due to preeclampsia or due to placental insufficiency. So you have to look out for the words preeclampsia and placental insufficiency in the history, and or 3 failures in the first trimester. So either 1 in the third trimester or 3 or more consecutive abortions in the first trimester. That is how you can remember clinical criteria. Lab mein there are 3 tests: anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein. Beta-2 glycoprotein. So this finishes off our beta-2 story. What is our beta-2 story? So where did we study beta-2 microglobulin? 2 places. It is the prognostic factor of multiple myeloma, and amyloid of beta-2 microglobulin is seen in patients who are undergoing dialysis. Beta-2 transferrin we had studied in ENT. This is used to confirm the presence of CSF rhinorrhea. And finally, beta-2 glycoprotein is what is seen in APLA. So 4 beta-2s you have to remember, right, all throughout 19 subjects. Now, lupus anticoagulant, very interesting, okay. The name says it's an anticoagulant, and it is an anticoagulant. If you look at in vitro, in lab, this is what we will see. We will see that there is prolongation of APTT. This is what we will see, that there is something called as Russell-Viper Venom test. This is where it behaves like an anticoagulant. It doesn't allow coagulation to happen. You also remember Russell-Viper, right? It was a vascular toxin causing DIC, hemolysis. So this is what in vitro is an anticoagulant. But actually, what is it doing in the body? You have procoagulant action. You have recurrent thrombosis, right? So this is where this is paradoxical. In vitro anticoagulant, in vivo procoagulant. All right. So this is about APLA. So what you need to remember in APLA is you will have 1 clinical plus 1 lab criteria to be fulfilled, and the treatment becomes low molecular weight heparin plus aspirin. Alright, so this is the treatment of choice for APLA in pregnancy. Now, just one caveat here, there was this last year very good NEET question where they said that there are recurrent abortions, So they said that there is one first trimester loss, then the female has a second trimester loss, and then she has a loss at 32 weeks because of placental insufficiency. What is the diagnosis? So in such conditions where you have improving outcome with every consecutive pregnancy, you also start to think of something called as Kasowitz law. Kasowitz law is with congenital syphilis, right? So is this congenital syphilis or is this APLA? See this very carefully. Congenital syphilis can never cause placental insufficiency. The moment I see 32 weeks and placental insufficiency, any pregnancy below 34 because of placental insufficiency fulfills clinical criteria of APLA. That can't be explained by Kassovitz law. So you have to be very careful. If the word placental insufficiency will be removed from this, the answer changes to Kassovitz law, right? So there's a very good question that was asked. So this is about APLA. Now let's talk a little bit about anticoagulation. Any woman who needs anticoagulation in pregnancy, most commonly with the context of heart diseases, how are you going to plan the treatment? So what you have to do in the first trimester, you know that warfarin is teratogenic. It is going to cross the placenta and it's going to cause epiphyseal dysplasia, as I will teach you. So I can't give warfarin in the first trimester. So that is why up till 12 weeks, you are going to keep her on low molecular weight heparin. Now you know that the embryogenesis is more or less complete in the first trimester. So now we will switch to warfarin from 12 to 36 weeks because warfarin, now the teratogenicity is lesser. The problem with continuing low molecular weight heparin throughout the pregnancy, it requires close monitoring, it is an injectable. So we can't have that continue for 9 months, right? So that's why we switch to warfarin. This is called as the warfarin switch. And at 36 weeks, now we are going to do the heparin switch. You're going to start her back on heparin because now delivery can happen anytime. If we keep her on warfarin, this is going to cross the placenta and it will cause hemorrhagic disease of newborn. So we don't want that. So more than 36 weeks, now you will bring her back on heparin, which does not cross the placenta and also has a short life of less than 24 hours. Whereas warfarin has a half-life of around 5 days. So we don't want that. Alright, so this is important. Now talking about extremely important topic, that is cervical incompetence. In the recent times, we've gotten a lot of questions from this. Okay, so cervical incompetence will present as recurrent painless delivery in the second trimester. This is where the female just begins to have cervical dilatation without any pain. So that is the characteristic painless abortions or painless deliveries which are happening, not abortions but painless deliveries which are happening in the second trimester. This is accompanied by painless cervical dilatation. Alright, so when to do the management? First is the clinical indication. Clinical indication is that you've had 2 or more deliveries because of cervical incompetence, means 2 or more painless cervical dilatation का history है, history of 2 or more deliveries because of cervical incompetence. So history of 2 or more painless labor, okay, in second trimester. Apart from this, if there is one history, so if there is history of one painless second trimester abortion plus ultrasound showing decreased cervical length. So ultrasound showing a cervical length less than 25 mm. So these are the 2 indications when you need to treat. Let's talk about ultrasound for a minute. So look at this. This is the fetal head here. This was supposed to be the closed cervix. Look at my hands here. This is how they're supposed to be. Now what happens here is the cervix just begins to dilate. Slowly, pura cervix open, baby comes out. So here what do you start to see on ultrasound? You start to see this opening. This is what is described as a funnel. So this is funneling. And what happens as a result of funneling? The cervical length keeps decreasing, right? So this is what we see as the cervical length. Any length less than 25 mm, or can I say any length less than equal to 24 mm is abnormal? Yes. So this is what we will remember here, that cervical length less than equal to 24. How does that help me? That helps me with the management. So what is the management that you have to do now? You have to do a cerclage. So this is the cerclage that is done around 12 to 14 weeks POG. That is the best time to do the cerclage. You will remember now the entire topic in one formula, 12 2s are 24. Cerclage done at 12 weeks. 2 indications, either clinical 2 or more cervical incompetence ka history and length less than 24 mm. So this is the one line summary you have to write, and this entire topic is revised. Okay. They asked you, what about non-pregnant? If there is history of incompetence, can I treat a not pregnant woman as well? You can. There are 3 procedures for that: lash and lash, Benson Durfee, and laparoscopic. If asked to choose, laparoscopic is the best, right? And if you are doing a cerclage in a pregnant woman, it is usually Shirodkar or McDonald, alright? And this is what is a kind of a purse string suture. Do you understand this? The cervix is opening, so take a suture around it and close it. So that is the purse string suture here. Absolute contraindication to cerclage is rupture of membranes. So this is very obvious, right? If the membranes are ruptured, now what is the point of closing the cervix? It's done, right? So now you can't do cerclage. So this is what you want to remember here. Moving on to medical diseases in pregnancy, extremely important: pregnancy-induced hypertension. So first, pathophysiology. This is because of failure of invasion of spiral artery by extravillous cytotrophoblast. So the invasion is not proper. So you want to remember extra spiral. What happens to TXA2 to PGI2 ratio? Obviously, it increases. TXA2 is a prothrombotic marker, right? So only when it increases will I have narrowing of the spiral arteries. So this ratio increases. A few definitions. Chronic hypertension is any blood pressure more than equal to 140 by 90 millimeters mercury, which is happening before 20 weeks POG, right? So this is before 20 weeks. This is usually because of a pre-existing medical disease that a mother would already have had. Gestational hypertension is when the same thing happens but now more than 20 weeks. So PIH or gestational hypertension is more than 20 weeks. Preeclampsia, pro matlab proteinuria. So for preeclampsia, we need proteinuria, which can be defined in 3 ways. The toughest, take urine for 24 hours if that's more than equal to 300 mg, very rarely done. What is usually done is a urine spot sample, calculate protein and creatinine, the ratio is more than equal to 0.3, or what is most commonly done in OPDs is you give a dipstick, and if it is 1+ persistent, that's proteinuria, right? So 3 methods to prove proteinuria: preeclampsia. Very important, what is severe preeclampsia? Severe preeclampsia, HELP, or they might write the term here, impending eclampsia. So what are the high risk features here? Any sort of edema developing, pulmonary edema, cerebral edema, these are high risk features. So they are going to use terms like blurring of vision with headache to indicate cerebral edema. They might use the term dyspnea to indicate pulmonary edema. They might use the term right upper quadrant pain, that can happen because of bleeding in the liver capsule, which stretches the capsule resulting in pain, or they will use the criteria of HELP. So what is the criteria for HELP? The name tells you everything. So here what we are going to use is the Tennessee's criteria. So Tennessee criteria, H is for hemolytic anemia. How do we prove hemolytic anemia? Either they will show you schistocytes on the blood smear. We studied this in hemat. Schistocytes are your cells, helmet cells, right? So these will indicate hemolytic anemia. Remember MAHA, microangiopathic hemolytic anemia, all short forms. So this is HELP, right? So you have schistocytes, or you will see that the LDH levels are raised, to be precise more than 600, or indirectly bilirubin is raised to more than 1.2. So this is hemolytic anemia. Then EL matlab elevated liver enzymes. This is where you check elevated OTPT. So LFTs are raised, and most important LP, low platelet, definition being less than 1 lakh per mm cube. So platelet less than 1 lakh, low platelet, same as dengue, alright, dengue criteria. So this is what are all of the features which indicate severe preeclampsia. Eclampsia means convulsions, right? So the moment you have convulsions, it becomes eclampsia. So now talking about the management of PIH, very, very important. All of these patients are going to get antihypertensives, right? The timeline of their termination of pregnancy is going to be different, but this is what we are going to be compiling towards the end altogether so that it becomes easier to remember. Right now, remember the specific management. So, all of these are going to get antihypertensives in pregnancy. So, you want to remember A, B, C, D. What is A, B, C, D? ACE inhibitors or ARBs, beta blockers, diuretics. These are contraindicated. Okay, what is the drug of choice? Drug of choice is labetalol. Labetalol is also a beta blocker, but it's a combined alpha beta blocker. It's an exception which is drug of choice. Okay, so this is what is labetalol. They've asked you the maximum dose, so you want to remember 2400 mg oral dose is the maximum dose. Apart from this, all of these others are safe in pregnancy. Better to remember what is contraindicated: A, B, C, D. Moving on to eclampsia. So, eclampsia, what you need to remember, what is the drug of choice? The drug of choice is magnesium sulfate. Extremely important, magnesium sulfate is not going to lower BP. It does not lower BP. It is actually a neuroprotective agent. What it does is it binds to the NMDA receptors in the brain, alright. So, MgSO4 is used for its neuroprotective ability. Extremely important. The regimen is Pritchard regimen. Pritchard regimen is your loading dose that you need to remember. So, this is what is the loading dose. Alright, so this is very, very important that you will not depend this loading dose on the renal function of a patient, because loading dose, as we have said, depends on the volume of distribution, whereas maintenance dose is what is dependent on the clearance, right? So, loading dose not dependent on renal function. Fine. So, you will not change this even if a female has renal insufficiency. That's a repeat question. So, what is the loading dose? The loading dose is 14 grams. So, what do you need to remember here? So, 14 grams, this is what we have to divide. 10 grams is given as an intramuscular injection. This is 50% weight by volume. So, you want 10 gram intramuscular, 50% weight by volume injected into each buttocks, right? So, this is what is to be done, whereas 4 gram is given IV. This is given as 20% weight by volume. So, how is this IV given? So, for making 20%, you need to know something. Each MgSO4 vial, so a 1 gram MgSO4 vial is actually going to be 2 ml in volume. So, when you take 4 gram MgSO4, that makes it 8 ml. Okay, and what you need to remember is 12 ml of normal saline. So, 12 ml of normal saline is to be added here. So, 8 ml MgSO4 plus 12 ml normal saline is going to give you 20% weight by volume. So, this has also been asked in an old AIIMS exam. Okay, so this is your Pritchard regimen. Therapeutic level of MgSO4 is 4 to 7 milliequivalents per liter. For monitoring, you need to monitor 3 things here. You are going to monitor the deep tendon reflexes. They are the first one to become sluggish or to be lost. So, this is the first change that is going to tell you about MgSO4 toxicity. You are going to monitor the respiratory rate. If that goes down, that is a sign of toxicity. And you are also going to monitor the urine output. Urine output is not monitored in order to see toxicity, but in order to see the renal function. Because if urine output is low, then we need to modulate the maintenance dose accordingly, right? So, this is not something which tells you about toxicity. That's important. So, you are going to monitor. As soon as you see any signs of toxicity, what is the antidote? The antidote is calcium gluconate 10%. Okay, very, very important. This is your cardio stabilizer because MgSO4 is going to cause CVS arrest, right? So, that's what you have to prevent. Give calcium gluconate first and then stop the infusion of MgSO4. So, this is all about magnesium sulfate, extremely important topic here. Next, let's talk about liver diseases in pregnancy. So, here you need to have a buzzword kind of an approach. For every liver disease, you want to know these, alright. So, this is where the first thing is HELP. You already know the criteria, so HELP shouldn't be a problem. You have to look for the components. So, as soon as you see hemolytic anemia, it can't be anything else. As soon as you see low platelet, it can't be anything else. And you will have elevated OTPT. This is what will overlap with others, but these two help you diagnose HELP. Acute fatty liver of pregnancy is something which has very high maternal mortality, okay. So this has high maternal mortality, and the problem is actually with the fetus. This is linked with the deficiency of long chain acyl dehydrogenase in the fetus, okay. So LCHAD enzyme is missing in the fetus, that is linked to development of this, and this is where you will have very high levels of OTPT, which are SGOT, SGPT, and you will be given hypoglycemia, you will be given hyperammonemia, right. So this is what shall be mentioned in the history, acute fatty liver, and this is what requires immediate termination of pregnancy. Alright, so that is important. When we talk about idiopathic cholestasis of pregnancy, extremely important for exam, your buzzword here is increased bile acids. Nowhere else will you read bile acids increasing, okay. So this is where bile acids are increased because there is cholestasis. The female will have a lot of pruritus. The treatment is UDCA, give ursodeoxycholic acid, and the termination should be at term. So terminate at 37 weeks POG. Unlike AFLP, this is usually linked to fetal morbidity, which is a little higher. There can be risk of preterm labor, all right, respiratory distress. So this is usually associated with fetal adverse outcome. That's why you want to terminate at term. Viral hepatitis, you know the most common viral hepatitis in pregnancy, the one which is most dangerous in pregnancy is hepatitis E. So hepatitis E, very important, has up to 20% maternal mortality in pregnancy. So this is the one where you have to monitor closely. Otherwise, every other hepatitis is just like the medicine counterpart. Okay. So this is about all of the liver diseases and their buzzwords. Extremely important. Next disease is gestational diabetes mellitus. In GDM, what you want to remember, first of all, difference between overt versus gestational. If the diabetes is present at the first visit, meaning if it occurs at the time of presentation below 24 weeks, before 24 weeks, that's overt diabetes. GDM is what usually occurs in the second trimester. So the screening of GDM first is at the initial visit, right? So that is essentially overt diabetes. Then we check around 24 to 28 weeks POG. That is when most women will be screened for GDM. That is when most women will be diagnosed for GDM. This is where you do a oral glucose tolerance test. So, what are these findings? So, what we use at AIMS are the IAD PSG guidelines. Apart from that, the other Indian guidelines are DIPSI guidelines. So, depending on what they give you, they'll mention these guidelines. In DIPSI, it's just one reading, 75 gram, 2 hour more than 140. In AIMS, what we follow? Fasting is taken, 92 or more is the reading. You give a 75 gram load at 1 hour 180, at 2 hours 153. So, 3 readings are taken here. If you want a trick to remember, 92. 9 twos are 18. Okay. And just wait for it. Here, what are we saying? 5 plus 3 plus 1 equals 9. 3 minus 1 equals 2. So, how are we reaching 9 and 2? In everything, you can remember, but it feels like just remembering the 3 numbers is easier than how the mnemonic looks like. Alright, so whatever. So, 92, 180, 153, 3 numbers. Any one is positive, it's considered to be GDM. Right, so this is the criteria. Extremely important, congenital anomalies. Will we see this in GDM or overt diabetes? Can't be in GDM. By 24 weeks anyways the baby is made, right? Embryogenesis is made. So this is what is only overt diabetes. Most common CVS anomaly is VSD. Most specific CVS is going to be TGA. Most specific overall, extremely important, is caudal regression syndrome. In caudal regression syndrome, there is sacral agenesis. As soon as you hear this, please think of gestational diabetes mellitus. This is what the baby will look like. You will see that the pelvis is not formed, absent sacral vertebrae. The most severe type of sacral agenesis is what is called as cyrenomelia. That is what is called as a mermaid baby, where the 2 limbs are also fused. So that's the most severe of this spectrum. Okay. What you also need to remember, macrosomia. Now, macrosomia is seen in overt, GDM or both? This is seen in both, right? So, this is seen in overt as well as GDM. Macrosomia is defined as any baby weight more than 4 kg. Now, this is what is the estimated fetal weight. Just want to tell you, for estimated fetal weight, we have various formulae like Johnson's formula. There are few ultrasound formulas which are Hadlock and Shefford. Okay, so this just on a side note giving you some more information. So these are formulas with which we can predict the fetal weight on the basis of few parameters, right? Overall, the most important parameter for fetal growth is going to be abdominal circumference. So abdominal circumference is the best parameter for fetal growth. Okay, so this is something on a side note. Going back to macrosomia, why does it happen? Remember, in biochemistry, we studied how insulin is an anabolic hormone, right? So what is happening here? Mother is hyperglycemic. Can I say fetus is by default hyperglycemic? Yes, because the fetus is receiving so much glucose, now the fetal insulin production becomes high. The pancreatic beta cells hypertrophy and they produce a lot of insulin. So this is what is happening. Too much insulin is an anabolic hormone, produces macrosomia. So this is where, if there is proven macrosomia, LSCS is preferred, because otherwise you may have risk of shoulder dystocia. Alright, so this is important. Liker, again, polyhydramnios. Can I say that the fetus is hyperglycemic? So there's going to be osmotic diuresis, just like an adult diabetic. Polyuria, polydipsia. Fetus here is our diabetic. So polyuria matlab osmotic diuresis. More urine means more amniotic fluid, right? But what happens when it becomes a neonate? Once it's out and the blood sugar level goes down, because now the mother is no longer giving the baby glucose, now what happens? The pancreas are used to making a certain amount of insulin because of their hyperplasia. So now when the baby is out, the baby develops hypoglycemia paradoxically. So this is what is called as the Penderson's hypothesis, that now the baby is at risk of hypoglycemia because of overproduction of insulin. Very important. Other complications, there can be hypocalcemia, hypomagnesemia. These babies are prone to developing RDS, respiratory distress syndrome. Okay, normally we see this in preterm, but infant of diabetic mother are more prone to developing this. Alright, so this is very, very important here. Apart from this, there can be polycythemia. Alright, so there can be polycythemia because more RBC, so that's why the risk of neonatal jaundice increases as well. Okay, timing of delivery, we will talk about it. So this depends on the control. If it is well controlled on insulin or diet, you will terminate at 39 weeks. Uncontrolled 37, and this is the concept for almost everything, which I will teach you all at once towards the end. Right? What have we written here? These are all indications for higher dose of folate. All of these are indications where the risk of neural tube defects is higher. Diabetes, anti-epileptic drugs like valproate phenytoin, history of previous NTDs, or sickle cell anemia. This is where you have to give a folate dose of 5 mg. Typically 4 mg, but we don't get that as a tablet, so that's why it's 5 mg. Otherwise, all female are gonna take 0.5 mg routinely, right? So this is where you have to take 5 mg, not just at the time of conception, 3 months prior, right? So that is how you have to start and continue throughout pregnancy. So this is all about folate. So now starting with RH isoimmunization, extremely important. So here we said, right, at the initial visit, we are gonna see the blood group of the mother. If she is RH negative, now you see the husband's blood group. If husband is also negative, perfect, they are made for each other. But if husband is positive, now there's a problem. So if the husband is positive, now you have to do the next test as perform ICT titer. Indirect Coombs test. As soon as you hear indirect Coombs test, think of RHIC immunization. As soon as you hear direct Coombs test, think of hemolytic anemia. Alright, so we have performed ICT. If ICT is negative, means she hasn't been exposed so far. She hasn't had exposure to the Rh antigen so far. That's great. So we want to keep it that way. You keep monitoring her every 4 weeks, and we have to now give her prophylactic anti-D, that is 300 microgram, which is around 28 weeks. And then once the baby is out, you will see the blood group of baby. Only if baby is positive, then we will give one more 300 microgram within 72 hours. Now, what is this anti-D? This anti-D is IgM or IgG? This is IgG. This is why it is called as RhoGAM, RhIgG. That is what is important. Why not IgM? First of all, we don't want. So here it is a little counterintuitive. You might think that IgM will not cross the placenta. That's why we are giving IgM. But no, this is IgG. We are giving it very little doses, right? The exact concept here is not very clear, but we are giving such that any antigen which may have come into the mother circulation, it's only that much that it can neutralize. It's not enough to now cross over to the placenta, right? So that's why we are giving 300 microgram is going to neutralize as much as 30 ml of fetal blood, right? So 30 ml of fetal blood, and that is what is the rough estimate, can be neutralized. So one is 28 to 32, that's prophylactic, and this is after birth, okay? Now, what if she is ICT positive? If the titer is less than 1:16, that's fine. You can keep monitoring her, but now instead of every month, every 2 weeks, okay? Here you don't give prophylaxis because she already has antibodies, so we don't want that to be increased, okay? So here we will not give. But now if there is a problem, if ICT is more than 1:16, you have to monitor her every 2 weekly for fetal ultrasound, where we check the middle cerebral artery and we check for features of hydrops. In middle cerebral artery, as we understood in peds as well, there is brain sparing effect, right? So what actually happens is the peak systolic velocity of the middle cerebral artery is going to increase if there is fetal anemia. It's opposite because we are trying to save our brain. So if the MCA PSV is more than 1.5 MOM, matlab multiples of median, it's just a way of expressing, then you will repeat it after 1 more week. If it is still more than that, now you will perform chordosynthesis, or there are features of hydrops, okay? So features of hydrops include fluid in every compartment of the body. So here you can see how there is this diffuse. Can you appreciate how the skin here is thickened, right? So that is what is anasarca. You can also appreciate that there is some effusion. Can you all appreciate this? These are the lungs and there is pleural effusion. In this child we don't see, but you may also have ascites, you may also have pericardial effusion. Any 2 out of these are positive. That is what is the criteria of hydrops. Any 2 compartments, ascites, pleural, pericardial, anasarca. Okay, so this is what is hydrops. So this is where we perform chordosynthesis. If fetal hemoglobin is less than 10, you will perform intrauterine transfusion, and you can keep repeating this 2 weekly and 3 weekly thereafter, and terminate at 35 weeks or later. So this is the whole management. You need to have this flowchart in your mind. Then there is this whole table of when to give anti-D. You don't need that. Remember, when will you not give? Because that's what the question will ask, right? So in threatened or complete abortions in the first trimester, we will not give. So the only place where you will not give is either a threatened abortion where the fetal cardiac activity is present, or complete abortion. Don't give methyl ergometrin. And as I said, 300 microgram will neutralize 30 ml of fetal blood, and the half-life is around 21 days. Okay, so this is about RH and anti-D. Let's talk about a few miscellaneous diseases. So anemia, what is the definition of anemia? Any hemoglobin less than 11 gram per DL, or I can say in other words, hematocrit is usually 3 times the hemoglobin. So hematocrit less than 33%. Most commonly, like we said, it is physiological anemia because of dilution. But if asked pathological cause, you want to remember iron deficiency anemia. Nutritional deficiency is the most common cause. Okay. The government of India, IFAPL, if you remember, Anemia Mukt Bharat, what did we remember? 20, 45, 60, 100, 400, 500. I hope you remember this table of iron and folate. So the last one, 20, 45, 60. 60 mg elemental iron, 100, 400, 500, 500 microgram folate. This is what is to be given in a pregnant female daily, right? Not just pregnant female, we remember every reproductive age group we are going to give this, right? So this is what is given OD. Is deworming recommended? Yes. Single dose 400 mg albendazole in the second trimester usually. So this is what is recommended as deworming as a part of the program. Now let's talk about how to manage anemia. So you have to see the level. If it is more than 7 gram per DL or it's less than 7 gram. If it's more than 7 gram and it's early pregnancy, now make this IFA tablet BD. Instead of OD, she's going to take BD. But if she is more than 34 weeks or she is non-compliant or not responding to oral treatment, now you have to start parenteral iron. But if she is less than 7 grams and she is less than 34 weeks, now you have to straight up start her on parenteral iron. More than 34 weeks or less than 5 gram. This is severe, right? Less than 5 gram or more than 34 weeks with less than 7. This is where now you have to give her blood transfusion. For parenteral iron, you can give iron sucrose that was available in our program. Nowadays, they also have iron carboxymaltose. So, either of these. What you want to remember is that the rise in the iron level is going to be the same with oral and parenteral. So, it's not like parenteral is going to be a faster rise in hemoglobin. Both have the same rise. It's just that if you can't tolerate oral iron, then only you'll prefer parenteral, right? So, that is what the concept is. Thyroid, we have already discussed. When we talk about a normal thyroid profile in pregnant woman, T3, T4 total will be increased because the TBG is increased. And what about free T3, T4? That remains normal. So, a pregnant female is euthyroid, just that her total levels are raised because TBG is raised. But if she is on treatment for hypothyroidism, we have to increase her dose, right? Because now more of the drug is going to be bound. So, I need to increase it, right? So, this we already know. Let's talk about amniotic fluid disorders. Here, what you have to remember, first of all, are some numbers. So, we can say Liker disorders in two things. One is the single deepest pocket or the single vertical pocket, all right. So, SDP, single deepest pocket, we can measure. So, we measure the amniotic fluid and 4 quadrants, okay. So, imagine this is the mother's belly. You divide it into 4 quadrants. These are the 4 quadrants of the Liker pouches that we have. We measure the deepest pocket in each of these quadrants. Remember number 2 to 8. Or what we can measure is a mean of all and add it. So, that is amniotic fluid index. A5, remember the number 5 to 25. So, these are your normal ranges, 2 to 8 centimeter, and this is an index. So, less than 2 centimeter is oligo, more than 8 centimeter is poly. Here, less than 5 AFI is oligo, more than 25 is poly. So, obviously, you don't have to remember this. You just have to remember 2 to 8, 5 to 25, and everything else is self-explanatory. So, now let's talk about the causes. Uteroplacental insufficiency, oligohydramnios. Renal agenesis, oligo. Posterior urethral valve, oligo. So, only 3 causes of oligo. Even in renal conditions, you want to remember, Bartter syndrome is something that can present congenitally, and that's the only place where it will have increased amniotic fluid, because Bartter, you remember, Bartter is just like furosemide, loop diuretics. Diuretics means more water, more urine. So, that's why polyhydramnios. Everything else in the kidney, it's low. So, just remember these 3 because all other conditions, polyhydramnios. Polyhydramnios matlab swallow. नहीं कर पा रहा baby. So, esophageal atresia, cleft lip, neural tube defect and omphalocele. So, any abdomen or neural wall defect you will have poly. Fetal anemia, we saw fluid retention, GDM polyhydramnios, twins, trisomy and encephaly. Everything is poly except these 3. So, that's what you want to remember. What are oligo conditions? The problem with each of them, what is the problem with oligohydramnios? It's a very tight space, right? So, oligohydramnios can be linked with amniotic band syndrome, right? So, you will have very, very tight uterine pouch here. and this is what is associated with anomalies like DDH and metatarsus adductus. So this is what is associated with a syndrome only, a spectrum whenever you have tight intrauterine space. Okay, and oligohydramnios is one such cause. Fine. Apart from this, in oligohydramnios, you may have risk of cord compression as well as IUGR. Okay. On the other hand, what about polyhydramnios? Polyhydramnios means abdomen is very much distended. Whenever there is too much abdominal distension, same concept. Remember, there can be preterm labor, there can be preterm premature rupture of membranes here. You may have cord prolapse here because there is too much fluid, right? Or you also have higher risk of abruptio placenta, right? So these are the conditions about Leica disorders. Very important box, where all do we give aspirin in pregnancy? APLA. Past history of PIH or chronic hypertension. So one thing very important, what is protective against PIH? So you want to remember, one is aspirin. Second, smoking actually protects against preeclampsia. Okay, so smoking is also protective against preeclampsia. So it doesn't mean you prescribe smoking, it's just that it's an association, right? Apart from this, another is calcium supplementation. Okay, so this could come as a question, party question. 3 things that can prevent preeclampsia: aspirin, calcium supplementation, and smoking. Multifetal pregnancy, we have to give aspirin. Overt diabetes and CKD. Basically, anything which predisposes to PIH, it's better to give aspirin, right? Moving on to heart diseases. So here, what you need to remember, that systolic murmurs up till grade 3, just like NADA's criteria we studied in pediatrics, that could be normal. But a pansystolic murmur and a diastolic murmur is pathological. But an exception, if you see in the 2nd to 4th intercostal space a high-pitched pansystolic murmur, that is what is mammary souffle, however you want to pronounce it. So souffle is a dessert, but whatever. So this is what is because of increased blood flow to the breast that develops. So that is what is this pansystolic murmur. That's physiological. The most common heart disease in general in pregnancy is mitral stenosis. And very important, what is the most common time? So that is related to the time when cardiac output is the maximum. So we have studied that maximum, this is immediate postpartum. Then 2nd stage of labor, when the mother is bearing down, and 34 weeks POG. Now, you can't really control this increase postpartum, but we can control 2nd stage. How can we control? We can reduce the bearing down. So, the delivery mode is normal vaginal delivery only, but instrumental delivery. Instrumental delivery will support the mother in the 2nd stage and reduce the bearing down. So, that's what we are trying to do here. There are a few indications. There's a WHO classification. You only want to remember this, where pregnancy is actually not recommended. So go through this list here. Here we have written peripartum cardiomyopathy. So this is important. For the first year after you develop peripartum, pregnancy is not recommended. After that, it's fine. Okay. So this is an important list you want to go through, where pregnancy is not recommended. Severe heart diseases. Peripartum cardiomyopathy is the third. It is systolic dysfunction that happens in the 3rd trimester or within 5 months postpartum. And remember, it is a systolic dysfunction that you have to prove. It is idiopathic. There is no cause that you can find structurally. Okay. So this is what is about the heart disorders. Now talking about twins, extremely important. The diagnosis part, I am sure you guys know. So look at this. This is where you see that these are the 2 twin babies separated by this amnion, and there is this widening. Can you appreciate this? So this is what is described as the twin peak sign, also called as the lambda sign. So this is the twin peak or the lambda sign. Thick membrane, essentially seeing that this membrane will be more than 2 millimeters because it has separate chorion, separate amnion. So this is dichorionic diamniotic twins. On the other hand, when you see that the membrane is thin and it is inserting perpendicularly like a T, this is the T sign, which indicates monochorionic diamniotic twins. So this is single chorion diamniotic twins. If you see, there is no membrane between the babies. They are in one sac. This is MAMC, monoamniotic monochorionic twins. Okay. This depends on the separation. So when you have the blastocyst, at what time does it divide? It's going to determine what kind of a twin you are. So DCDA matlab independent baby, right? Both babies have their own chorion or own amnion. Why are they independent? Because their separation happened very early. So they're independent, 0 to 4. 4 to 8 days, MCDA. 8 to 12 separated so late that now they are codependent. They share their amnion and their chorion, and if the separation happens too late, now you are attached to one another physically. So that is what are your conjoined twins. Conjoined twins, the most common type is parapagus. If that is not there in the option, thoracopagus. So parapagus is essentially the entire torso, whereas thoraco is specific chest. So makes sense, right? So this is about conjoined twins. Now let's talk about a few complications in twins. These complications tend to happen in chorionic, monochorionic twins. So if I ask you what is the most important prognostic factor for twins, it is actually a shared chorion, monochorionicity. Because when you have a common chorion, now there are these anastomoses which develop, particularly deep anastomosis. So there are these deep arteriovenous anastomoses between the two fetuses through which they share blood. So what happens is one twin becomes the donor and one twin becomes the recipient. So there is this unidirectional. Instead of being these bidirectional anastomoses, these are normal anastomoses. But normal was supposed to be bidirectional blood flow. Okay, give and take hona chahiye. But here it's becoming one-sided. So this is abnormal because they are becoming unidirectional. So now what happens? Actually, whenever you have an unequal relationship, both of these babies are gonna suffer, right? So this is where now this donor baby, it's gonna go into fluid insufficiency. There's reduced fluid renal insufficiency, whereas this recipient baby goes into fluid overload. So this baby goes into high output cardiac failure. So eventually both babies will die. So that is what is happening, and this syndrome is twin to twin transfusion syndrome. TTTS. So for this, there is a Quintero staging, hasn't been asked. If this comes, I'll take a party. So stage 1 is liker problem. One baby with oligo, one with poly. Stage 2 is where now the bladder comes into play. The donor baby has no blood left, the bladder collapses. That's a sign that urine output, remember urine output is the sign of perfusion. So this says that the baby has less blood. Stage 3 is where you start to see Doppler abnormalities, IUGR changes, and 4 is fetal height drops. So, first is liker, bladder, Doppler, and then height drops. Okay, so these are the 4 stages. How do we treat? So, you can do laser ablation, right? You can do laser ablation of these abnormal anastomosis. So, that is how you will ablate these vessels, deep uterine anastomosis, and you will treat twin to twin transfusion syndrome. There is another disorder which is TAPS. It is a milder form or a variant of TTTS where you just have twin anemia, polycythemia, right? So here also you have this unequal relationship, but now it's not presenting as liker changes. So it never reaches the stage 1 also. So it's only in the hemoglobin count. One is anemic, one is polycythemic. There is one more such term called TRAP. TRAP is where you need to remember a buzzword. There is an acardiac twin. So there is this acardiac twin and then there is a pump twin. The pump twin is actually the baby who's going to make it because he has a heart. The other baby doesn't have a heart. So this is unidirectional blood. So this is where now saving this twin is not going to help us. So this is where you're going to kill this twin by injecting potassium, right? So you're going to inject potassium into this and this twin is only making the other baby die. So we don't want that, right? So that is what you have to remember. This is TRAP. This is twin reversed arterial perfusion. Okay, so these are a little extra things I am telling you, but you never know, right? Obg2 is one thing where go in as much detail as you can. Okay, so twin to twin transfusion, TAPS and TRAP. You had a question about delivery of these twins. So look at this. If the first twin is vertex. You can see the first twin is vertex. In that case, you can do normal vaginal delivery. So, normal vaginal delivery, the only condition is first twin should be vertex. What about first twin non-vertex? Any other position like breech, transverse, not vertex. So, first twin not vertex. In that case, you have to do LSCS. Okay, so I'm just going to write it here. So, this is LSCS, this is normal vaginal delivery. Apart from that, something unique to our MAMC twins, monoamniotic, monochorionic, they can have cord entanglement, right? Because they are sharing the amniotic sac, so cord can get entangled. So, this is what we need to know as far as the delivery timing are concerned towards the end. Okay, same page, everything we will study. Moving on to third trimester bleeding, or basically any bleeding which is after viability. Okay, before viability we saw ectopic versus molar versus abortion. Beyond 20 weeks essentially is what we are referring to here as P3 bleeding, but essentially anything after 20 weeks, this is what is antepartum hemorrhage. So, this is what is the approach to antepartum hemorrhage, extremely important. The first scenario here, you are having, first of all, history of warning bleed. There was some bleeding which then stopped. So, that's first buzzword. Second, what are the risk factors for this condition? They'll give you, she has a past history of LSCS or multiparity or a smoker. This is why smoker becomes a risk factor. Painless is your buzzword. So, if they say painless, bright red blood, soft uterus, fetal heart sound is normal. The fetus is not a problem here. Fundal height equal to POG with malpresentations. These are your buzzwords. Apt test negative, I'll talk about it. What are we dealing with? This is placenta previa. What is placenta previa? Placenta previa is a low-lying placenta. Let's look at this. So, this is the classification. This is the older one. Now, we have made it simple, only two types. If it is within 2 centimeters of the os but not touching the os, that is what we call as low-lying placenta. No term as marginal. Whereas, if it is touching the os, it is covering the os, that is placenta previa. No term as complete or partial previa, right? So, only placenta previa. Right. So, two terms, low-lying versus previa, whereas this was the older one. So, I am not deleting, you just see older and new. Alright. So, within 2 centimeter or covering. What happens here is you have a placenta that is inferiorly located. So, now this will start to bleed. So, it's the mother's blood which is being lost here rather than the fetus's. What is extremely important? It's a low-lying placenta. Never ever do a per vaginal examination. So, the first thing they'll ask is, will you do a PV? Never. Never do a PV or a per speculum examination, right? So, no PV, no PS. But can I do a TVS? Yes, that is in fact the investigation of choice. Transvaginal sonography, we don't go too much into the os. We don't even reach the external os. We keep the probe in the vaginal cavity itself. So, that is what is not contraindicated. So, they can give you this image. Look at this. This is the urinary bladder here, and you can see this is the placenta and this is our os. Do you remember the cervix? So, this is the os. So, you can see how the placenta is covering the os. So, this is what it will look like on an ultrasound. So, what do you want to do now for placenta previa? Very, very important. This is where you will not do normal vaginal delivery ever. Okay. So, you just have to see the timeline. If the timeline, the golden number here is 37 weeks. If the baby has reached more than 37 weeks POG, now you are going to do an LSCS, elective LSCS, emergent LSCS, whatever you want to call it. Less than 37 weeks, if everything is good, mother, fetus, both are stable, you can just wait, right? You can do conservative management, and then at 37 weeks, you can electively do an LSCS, and this regimen is called McAfee-Johnson regimen, but only if everything is good. Okay, so this is about placenta previa. Remember the number 37. Again, we have painless blood, but now marked fetal distress. You are seeing that the CTG, cardiotocography, is showing a sinusoidal waveform, meaning now it's not the mother losing the blood, it's the fetus losing the blood. And we see apt test is positive. So this is what indicates fetal bleeding. Fetal blood vessels coursing through the os got ruptured and you have vasa previa. This is where things are going to go downhill very, very quickly. So you have to do an emergent LSCS, no other option, because fetus is losing the blood. Now, we are just going to see blood coming out. How do I know whether it's mother's blood or fetus's blood? And that is where apt test comes in. So apt test, you want to remember, is an alkali denaturation test. The fetal blood has higher levels of hemoglobin F, which is resistant to denaturation by alkali. So that's what we are checking. We add 1 ml NaH, maternal blood degrades, fetal blood remains red. Okay, so this is a qualitative test. Alright, so alkali tells you everything. A for apt, L for qualitative. Whereas the other test, KB test, you want to remember, is used in context of RH isoimmunization to calculate. So this is where you have quantitative test, which is an acid denaturation test. Okay, so just remember alkali, right? You get this and everything else can be made out from the other. So this is done. On the other hand, instead of painless, now they are giving you painful dark red blood. There is tense tender uterus, fetal distress hair, and fundal height is more than POG. This indicates that there is some component of concealed hemorrhage as well, and this can be linked with DIC because of release of tissue thromboplastin. What are we talking about? We are talking about abruptio placenta. So abruptio placenta, remember, pain and tender uterus. So now the golden number is 34 weeks. As soon as we see that the POG is more than 34 weeks, you have to induce. This is where you don't have to do LSCS, you can do normal vaginal delivery. So you have to induce her. Less than 34 weeks also you have to induce, but you want to just ensure lung maturity. So steroids followed by induction of labor. What is very, very important here is you will never ever give tocolytic. Never give tocolytic in abruptio placenta. Okay, so this is extremely important. They have asked this question a lot of times. 34. So essentially takeaway is two numbers, 37 weeks for placenta previa, 34 weeks for abruptio placenta. A modified or a variant of abruptio placenta is this. This is completely concealed hemorrhage. What you can see as these bleeding within the uterine wall. So this is what is called as placental apoplexy. Remember how we said pituitary apoplexy, bleed into pituitary. This is bleed into the uterus. So this is placental apoplexy or called as Cuvilliers uterus. Just that it looks very abnormal. You would think I would have to do hysterectomy, but no, that's the whole question. This is not an indication for hysterectomy. Okay, so this is very, very important. Next, we are talking about another extremely important spectrum that is called as morbidly adherent placenta or the placenta accreta spectrum. Placenta accreta spectrum or morbidly adherent placenta. This includes three types. So there is placenta accreta, increta and percreta. So just gonna use a new pen, new page. Accreta, increta, percreta. The name tells you everything. Accreta is where now these chorionic villi are adhered to the myometrium. Increta is where they are invading into the myometrium, and percreta is where they are perforating or penetrating the myometrium and going into adjacent organs. Okay, so what happens here is, this is the placenta, this is the myometrium. Normally, there is this zone where there is a difference between the two. Here that zone is getting disrupted. You have more and more infiltration. From accreta, just adherence, increta, invasion, percreta, penetration, right? So this is what is happening here. So the ultrasound findings for this placenta accreta spectrum, ultrasound is your first investigation. What you will see is that this zone here between the placenta and myometrium becomes very, very thin, and you see these placental lakes, all right. So this is what the ultrasound will show you. There is this thinning of this zone here between the myometrium and placenta. So you can't even make out this darker part, hypoechoic, what you are seeing is the myometrium and this is the placenta. So there is this thinning of the zone in between the two, and what do you see on Doppler are these many lacunae. These are what are described as placental lacunae or placental lakes. Okay, so this is what you will see. The investigation of choice here is MRI. So in doubtful cases, MRI is very good at showing a surrounding organ infiltration. So what you have to make sure here you have to take consent that there will be a lot of blood loss. This might not come out very easily. So you have to take consent for high blood loss, keep blood ready. You have to take consent for hysterectomy. If this placenta is not separated easily, you might have to do a hysterectomy as well, and that's the main treatment. If you can't remove it, you will have to do a hysterectomy, and there might also be associated bladder injury because it infiltrates into bladder very commonly, right? So these are the three consents. Bowel injury can happen, but rarest out of all of these. Okay, so this was asked in AIMS once. So this is what you need to know about placenta accreta spectrum. All right, moving on to types of placenta, just to complete the topic of placenta here. So what are you seeing here are the few variants. So this one is your bilobed placenta. If you see two lobes, but one is a baby small lobe, so this is cute. So from cute, you will remember succenturiate. Okay, so this is where you have a cute lobe. But this cute lobe is not so cute because this is what could be retained. You are in a hurry, you remove this big part of placenta and the cute lobe stays behind. So this is what can be retained placenta. Okay, and this is what happens to be the most common cause of secondary PPH. Okay, so this is the most common cause of secondary PPH. Secondary PPH matlab more than 24 hours after delivery. Okay, then what you see here are the insertion of the cord at a margin. So this is what is called as a marginal insertion, or we can say ki dur hai, battle se dur. So this is what is battle door placenta. Then you can see this. This is where the membranes, particularly the membranes, are coursing separately. If these are fetal membranes, this is when you will have these fetal vessels. This is when the membrane will cause vasa previa, right? So this is what is described as velamentous cord. This is very important, velamentous placenta. If these are fetal vessels which are coursing over at the os, this is what is going to result in vasa previa. This is where you have rolled out edges at the margin. So this is circummarginate. Whereas if it becomes severe, this is what is circumvallate. So these are rolled out edges. Now let's talk about labor. All right. So now what we are going to be discussing, stages of labor, extremely important. So first have a broad understanding of things. So stage 1 labor is from the onset of labor till full cervical dilatation. Okay, so this is from the beginning till full cervical dilatation. We'll come back to it. Stage 2 is where the mother is going to do bearing down, and this is when there is expulsion of the baby, right? So this is expulsion of baby. Stage 3 is where you have expulsion of placenta, and stage 4 is the golden hour after pregnancy, golden 1 hour postpartum, where you have to monitor the mother's vitals, right? Now going back to stage 1. So stage 1 is divided into latent and active phase, the definition of which is the most controversial thing ever. So originally, so you'll be given these, okay, only then you can mark this. So original or Friedman curve was at 3 centimeter, that at 3 centimeter active begins. We start plotting the WHO partogram at 4 centimeters dilatation. WHO then defined active stage to be from 5 centimeter, and this is how we now follow our WHO labor care guide. That is what is now followed. We don't follow WHO partogram anymore, so that's why it's been changed to 5 centimeter. But ACOG differs here and says that keep it 6 now, keep it 6 centimeter. So soon in a few years we'll be at Keep it 1 only at 10 centimeters. So what you have to remember? 3, 4, 5 and 6. Let's talk about a few questions here. When we talk about the active phase, what is defined as active phase? Arrest. Before I go to arrest, what is protracted active phase? Protracted matlab slow active phase. So this is defined as a nulliparous woman or a multiparous woman. In a nulliparous woman, if the onset or the progression of labor is less than 1.2 centimeter per hour, in a multipara, less than 1.5 centimeter per hour. Normally, it is 1 centimeter per hour, the dilatation should progress. So, arrest is when it's been 4 hours. 4 hours, it should have been 4 centimeter dilatation, but here there is no change. So, if there is no change in dilatation for 4 hours, this is what is the definition of second phase or active phase, not second phase, of active phase arrest. Okay, so no change in dilatation, but you have to ensure that there are adequate contractions. So adequate contractions, what are adequate contractions? I'll get to it, but you remember these 3 numbers for now. Let's talk about the WHO recommendations for second stage of labor. Very important. Look at this maneuver. This is Ridgen maneuver. Ridgen maneuver is recommended. This is where when the head comes out, there's going to be flexion and then deflection. So we are essentially supporting the perineum and supporting the deflection of the baby here. Warm compressing perineum recommended. Fundal pressure, pushing the baby. Baby, go out faster. Don't want to do that. Episiotomy routinely is given in India, not recommended. Lithotomy, invariably in India, you put all your women in lithotomy position for delivery. Don't do that, not recommended. So these are the recommendations for second stage of labor. Third stage of labor, very, very important. You get a lot of questions from active management of third stage of labor. Active management का मतलब है primary prevention in PSM terms, that we are trying to prevent PPH by ensuring that the uterus tone comes back quickly. What we do here is prophylactic. Everybody gets 10 unit oxytocin within 1 minute. So this is what should be given intramuscularly or as IV infusion, never as bolus, because that can lead to refractory hypotension. Do controlled cord traction, don't pull it, otherwise uterine inversion will happen. So controlled cord traction is your modified Brandt Andrews technique. Intermittent assessment of uterine tone and delayed cord clamping. So delayed hai, not early. Delayed cord clamping, why? In order to prevent fetal anemia or baby's neonatal anemia, right? So that is why delayed, except birth asphyxia. Obviously, when the baby is not breathing, you're not going to be like, wait, I'll give you 1 minute later. Can't do that. So birth asphyxia, early cord clamping. Second indication, RH isoimmunization. You don't want mixing of the blood with the mother. And third, very, very important, is HIV. A little controversial also, because different guidelines say different things, okay? So you have to look at the options and decide. Fine. So this is terms and conditions apply. So this is what we need to know about active management. The next point that I need to teach you is about the cardinal movements. So what are the cardinal movements that happen at the time of labor? This you will remember with a story. Let's say that you got engaged, okay, to a boy. Fine, so engagement. In our country, there is only one criteria for boy for engagement. First is he should be a boy. Second is he should be decent, right? So decent boy, you got engaged. But turns out he is not decent. So then what are you going to do? You have to file FIR. So that's what you'll remember, flexion IR, internal rotation. Once you do that, all of your girlfriends, all of your friends are going to crown you. They're going to say, oh, you are a queen. So that's when crowning comes in. And now who is that boy for you? That boy is your ex. So now you have to remember 3 sets of XNR. So extension, restitution, external rotation, expulsion, rest of the body. So these are your changes. So you want to remember engagement, decent, FIR, crowning, XNR, XNR, XNR. Now crowning is not really a cardinal movement. It's just before and after crowning they can ask you. Alright, so that's how you will remember cardinal movements. Next, let's talk about partogram. So this is old news now, but they can ask you old news. So partogram was something that we were plotting from 4 centimeter dilatation. All right. So this is being plotted at or equal to 4 centimeter dilatation. So now look at the partogram. So just for historical purpose, I'm going to go through this. So what all do you plot? Fetal heart rate, you're going to plot the liker. What about the liker? You're going to plot one of these letters. So I matlab the membranes are intact. There is no liker yet. If the amniotic fluid is clear, that's C. If it is bloody, that's B. M matlab meconium stained, and A matlab absent, right? So that indicates severe oligo. So this is what is about the liker that you have to write as a letter there. M matlab molding. How do you assess molding? There is a score. Bones separated, bones touching but can be separated, bones overlapping severely. For practical purposes, +3 matlab it becomes an indication. It tells you that there is severe cephalopelvic disproportion. You have to do LSES. But for exams, you can also remember that anything beyond 2+ is also abnormal only. You should do LSES. Alright. So this is what we need to remember here. Then cervix. This is where you start plotting. So the first point is you start plotting at 4 centimeters. Okay. So here what you need to remember, what is going to be the first plot? So the first plot is always on the alert line. Alright. So basically, let's say she comes to you at 4 centimeter. This is where your first marking is. You go to her 4 hours later. So let's say this is when she came. So 1, 2, 3, 4. At 4 hours, where is she? So at 4 hours, 1, 2, 3 and 4. If at 4 hours, she is still on 4 centimeter. So this is where she will be at. Okay. So 1, 2, 3. One more, right? So now she will be here. So this means she has now reached the action line. So this was what we said was arrest. So arrest matlab anything where you have a horizontal line and it will cross over to action. This is mainly for PHCs. Alert matlab this is where you should start to consider referring her to a higher center. Action line once crossed matlab you have to do LSES. Right? So this is what is about the cervical plot. If she progresses normally, like we say that 1 centimeter per hour, you will see the next one here, next one here, next one here. Okay. So this is where this is normal labor, where we are, where everything is okay. All right. Now talking about fetal head descent. So fetal head descent is what is measured with respect to the ischial spine. Okay, so with respect to ischial spine is the station 0. Above it 1 centimeter minus, below it 1 centimeter plus. Okay, so this is what you need to know. Contractions per minute. So this is where we talk about good contractions. So good contractions ka matlab hai 3 or more contractions in 10 minutes. Okay, so 3 or more contractions in 10 minutes, each lasting 45 seconds. Okay, so this is what you need to remember, 3 or more in 10 minutes, each lasting 45 seconds. So this is how they grade it. Okay, what they do is this shading. If it is dot dot dot, matlab poor. If they do like lines, that's moderate, and what are good contractions are the solid line. So more than 3 per 10 minutes, this is what indicates good contractions. Whether or not oxytocin is given, other drugs are given, and what do we monitor in the mother? Pulse, BP and temperature. So you monitor fetal heart rate, mother pulse, mother BP, mother temperature, and whether there is any urine protein or ketone bodies. This is a WHO simplified partogram. As it is, it was simple only, but now they have just made colors that if she is in the green zone, for example, she is here and she is progressing almost 1 centimeter per hour, she is in the green zone. If little bit slow also, we see that okay, yellow mein aa gaya. If she is static, matlab she is come into red. So this is what just gives you a color coding. These graphs can be tested. So look at the first one. This is normal. The second one, what do we see? In the active stage, you are seeing that for almost more than 4 hours, in fact, she's at the same dilatation. So this is what is defined as the arrest of active stage of labor. Look at the next curve here. What are you seeing? You are seeing that it's progressing but at a very slow rate, between 12 hours to 24 hours. Almost 12 hours we are seeing that she has not progressed from like 3 to 10 centimeter, which is way below, less than 1.2 centimeter or 1.5 centimeter. So this is what is protracted active phase, right? So this is protracted active stage. Whereas what do you see in this one? That the latent phase is only taking so much time. So this is what is a prolonged latent stage. Here you don't really intervene much. Prolonged latent stage, just the definition you have to remember. So it is different for nulliparous and multiparous women. More than 20 hours for a nulliparous woman and more than 14 hours for a multiparous woman is the definition. So basically all the numbers 14 and 20 for protracted active, less than 1.2 centimeter per hour or less than 1.5. The former is for nulliparity, this is for multiparity. RS for everybody is more than 4 hours, no change with adequate contraction. So all numbers in one place. Now all of this has changed. Now what we follow is labor care guide called as the next generation partogram. Here they talk good things about it, that this is where you will assess the mother and baby, record, check reference threshold and then plan. All right. So this is basically having a higher threshold for intervention, right? So you are not intervening too quickly. So this is what this says. This makes this very simple for us. They have given the high risk features, that this is when you start to get alerted. You can see there are no alert action lines. When do you start plotting it? This is plotted at more than equal to 5 centimeter dilatation. Okay. So what are the high risk points where you need to alert? If there is no companion, she is taking analgesia or oral fluid intake is not happening, or she is in the supine position. So you need to monitor that. You remember, right, that a pregnant woman should not be in a supine position. Why? Because there leads to IVC compression called as supine hypotension syndrome. So always make it a point that a pregnant woman is in the left lateral decubitus, so that the pressure of the right IVC is decreased, the pressure is decreased, so that more blood can reach the heart. All right, so that's something very important. Then any fetal heart rate less than 110, more than 160. Decelerations, late decelerations are abnormal. Amniotic fluid that's meconium stained or bloody is abnormal. Fetal position, whether it's occipito-posterior or transverse, not occipito-transverse, just transverse lie. Capit and molding abnormal. Pulse 60 to 120, systolic BP, diastolic, temperature, urine for the mother. Contractions, as we said, 3 are adequate, less than equal to 2 abnormal, more than 5 indicates tachysystole. Okay, so this also we don't want. This is the definition of tachysystole, where you have more than 5 contractions in 10 minutes. Duration, we said adequate is 45 seconds. Now, this is where the major changes. What you now have to do is, we look at what centimeter of dilatation she is at. If she spends more than equal to 6 hours at 5 centimeter, that's abnormal. If she spends more than equal to 5 hours at this, that's abnormal. So they have basically given these timelines that isse zyada time you can't spend in this stage. So they've completely flipped the concept here. This is fetal head descent remains the same. Everything else remains the same. Oxytocin, assessment and plan. Alright, so this is what you need to remember, and it's a shared decision making. You take mother into account as well. Ask her what she wants. Alright, so this is what is the next generation partogram. Okay, so now let's talk about postpartum hemorrhage. Extremely important. So every step here, you know, how are you going to manage the drug dosages, everything becomes very important. Okay, so first of all, postpartum hemorrhage, what is it defined as? There is going to be some blood loss in every woman, but what is significant pph? So here you have to remember two numbers: more than 500 ml in a vaginal delivery or more than 1000 ml in a cesarean section is defined as significant postpartum hemorrhage. And the timeline, primary pph, as we said, is within 24 hours, more than 24 hours, it's called secondary pph, and the cause is retained placenta. For primary PPH, this is where we are talking about primary PPH. The most common cause here is atony of the uterus. Okay, and that is why we were doing active management of third stage of labor in order to prevent this. So let's talk about it. The immediate steps here would be to call for help and resuscitate, right? So this is basic. They'll go beyond this and ask you the next steps, all right? So call for help, resuscitation, start her on IV fluids, wide bore cannula. You'll also put a Foley's catheter if she's already not on a Foley's, because sometimes a distended bladder can also affect the uterine tone. So you want to remove, you want to empty the bladder. So put a Foley's. Now, our main approach starts with palpation. So, if the uterus is atonic, this is what is the most common cause. If it is contracted, means likely there is some sort of trauma. So, traumatic PPH, so you explore. If there are any perineal tears which you can see, you are going to give hemostatic sutures. If there is suspicion of uterine rupture, you have to take her up for laparotomy, and this is what we'll deal with separately. Right now, the whole focus is on atonic PPH. So, the first thing you are going to do is uterine massage. So, this is where a bimanual uterine massage comes in. So, you have one hand inside the vaginal cavity, one hand on the suprapubic aspect, and you do a massage. So, that's the first step. Doesn't respond, start pharmacotherapy. The first drug that we have to give is oxytocin. So, we have to give a fast infusion of oxytocin, that is 40 units in 500 ml normal saline. Following this, we are going to give methergin. If you remember methergin, this is methyl ergot. It's an ergot derivative vasoconstrictor. So, 0.2 mg IV every 2 to 4 hours methergin, followed by blood transfusion. Now, methergin is a vasoconstrictor. So, these are the contraindications of methergin. Don't give it in hypertension, peripheral arterial disease, RH and heart disease, and also in twins, right? Particularly after the first twin is born, you don't want that. So, this is where you are not going to give methergin. Basically, anywhere where you don't want vasoconstriction. This is done. So, we've given oxytocin, we've given methergin, blood transfusion, still atonic, carboprost intramuscular 250 microgram for a total of 8 doses every 15 minutes. So, they have asked you what is the maximum dose. Maximum dose becomes 250 into 8, so 2 mg, right? So, carboprost, as you know, is prostaglandin F2 alpha. The only contraindication here is asthma. 2 times asked in NEET. Okay, so this is PGF2 alpha asthma. Then you switch to misoprostol. This can be given per rectally, 800 micrograms. So this, as you know, is PGE1. So what is very important is there is no role of PGE2. PGE2 is what is dinoproston. That is what we have already learnt in pharma, right? General pharma. This is dinoproston. This is what we call as our Cervi-Prime gel, isn't it? So, this is for induction of labor. This has no role in PPH. Remember that. So, they can ask you all are used except kind of a question here. Following this, you are going to prepare for uterine tamponade. What is uterine tamponade? So, this is where technically either you can put a lot of gauze piece, hemostatic gauze piece rolled up and put into the uterus, or you could have this balloon that is called as Bakri balloon. Have you ever seen this in India? No, you would have seen Bakri and balloon, but not a Bakri balloon, right? So, for India, what we use is a Jugaad Bakri balloon, that is a condom catheter. So, this is where you take a Foley's and you tie a condom over it, and this is what you will distend, and this is a Jugaad Bakri balloon. Okay, so this is what you're going to use for tamponade. Following this, you will go for devascularization procedure. Before that, they also recommend taking some hemostatic sutures, which are called as your B-Lynch, Choi, Heyman, right? So, these are a few sutures that can be taken. Devascularization procedure, what is the order here? So, first, obviously, uterine artery. We had discussed this yesterday, wherein in uterine artery, I talked to you yesterday. Yours could be the same day, but uterine artery is what courses through transverse cervical ligaments, right? So, that's where you're going to block it, followed by utero-ovarian anastomosis, followed by internal iliac. Will you block the complete internal iliac? No, only the anterior division, right? So, only the anterior division, because that's where uterine artery comes from. If all fails, the last resort is going to be hysterectomy, right? So, very, very important order. massage followed by pharmacotherapy, so oxytocin, methergin, carboprost, misoprostol, tamponade or sutures, devascularization, and then hysterectomy. So all of this is extremely important. Few other complications of delivery. What do you see here? This is what is shoulder dystocia. So this commonly happens in macrosomic babies. So this is shoulder dystocia where the shoulder is stuck, right? So what do you do? So you want to remember, first call for help, evaluate if episiotomy will help here, do an episiotomy. But what is usually asked is the position. So Mac-Roberts position is essentially extreme lithotomy, right? What they ask you in Mac-Roberts position, what is the nerve that gets injured? So you want to remember, this is where you have meralgia peristhetica, which is lateral cutaneous nerve of thigh. Okay, so M for M. Don't confuse this with normal lithotomy. Normal lithotomy stirrups can compress the common peroneal nerve, right? So that is CPN. That's different. This is Mac-Roberts, meralgia, LCNT. All right. If not, next you will apply suprapubic pressure like shown. They'll give you fundal pressure in the option. That's wrong, okay? What you have to do is give suprapubic pressure. Next, you will try to rotate the posterior shoulder. So, posterior shoulder rotation, this is what is called as Wood's corkscrew maneuver. Next, you will ask the patient to be on all fours. This is what is called as Gaskin's maneuver, and the last resort. If shoulder is not coming out, put rest of the baby inside. This is called as Zava-Nelli maneuver. Alright. So, these are the steps of shoulder dystocia. Next emergency, they'll describe that a woman is in sudden severe pain and shock. This is not even hypovolemic shock because of hemorrhage. There is little blood loss. This is more commonly neurogenic shock that happens. And then if there is a lot of blood loss, can become hypovolemic as well. But essentially, neurogenic. And what will be the buzzword is that the fundus is not palpable at the umbilicus. Normally, immediate postpartum, the fundus reaches the umbilicus. So, let's first discuss normal involution. Immediately after delivery, lower border of umbilicus around 20 weeks. Day 1 finger breadth. Day 2, 2 finger breadths below the umbilicus. So, this is a very controversial question. Just remember 2 finger breadths. At the end of 2 weeks, it now becomes a pelvic organ, and at the end of 6 to 8 weeks, it reaches pre-pregnant. So, this is where complete involution you have to answer 2 months. 2 weeks pelvic organ, 2 months complete involution, right? So, now going back, it was supposed to be at the level of umbilicus, but it's not there. Where is it? You've pulled it out. Remember we said do controlled cord traction. Now if you pull it, what's going to happen? The uterus also accompanies the cord. So this is what is classic description of uterine inversion. They have asked you what will you do next. The first step is whatever you are giving as your contraction, you have to stop it. Stop oxytocin. This is the first step. And then once the uterus is lax, now you will try and position it back. So this is what is manual replacement using Johnson's technique. Once this is there, then you will start oxytocin again. But first step, stop oxytocin. This will be asked to you. Next, unexplained shock. So this is where this is a diagnosis of exclusion and buzzword being difficulty breathing within 30 minutes, DIC, no fever. This criteria has been asked twice. This is amniotic fluid embolism. This is something which you have to remember as a diagnosis of exclusion. And if they describe intense pain, fetal parts palpable superficially. So this is where the fetus is still inside, and now what has happened? There will be history. They'll give you history of past cesarean section, more with classical, then lower segment cesarean section, or history of myomectomy. Essentially any uterine scar ka history. This is what is rupture. So this is uterine rupture. The buzzword here is fetal parts palpated superficially. Another image-based complication, this is what is a vulval hematoma. They'll ask you what will you do next. So the answer here is compression. Most of the hematomas are going to resolve this way, but the last resort here is going to be devascularization of internal pudendal artery. Don't block uterine artery here, right? So that's not going to cause this. This is internal pudendal artery embolization, right? So this is what you need to know. As far as complications are concerned, extremely important page. Little bit about Doppler in pregnancy and IUGR. Remember in PEDS I told you it's abnormal Doppler indices. What Doppler? It's umbilical artery Doppler. This is the artery of choice for IUGR. So, 3 parameters you need to know. This is what is your normal umbilical artery Doppler, where you see this is systole and this is diastole. The problem happens, the diastolic flow keeps decreasing. So, the first change actually is the systolic to diastolic ratio. S by D ratio, what should happen? Increase or decrease? Because diastolic flow is decreasing, the S by D ratio increases until you see that there is absent end diastolic flow. So, this is absent end diastolic flow. What do you want to do? Timeline 34 weeks. If more than 34 weeks, immediate termination of pregnancy. Less than 34 weeks, you want to give a dose of steroid, repeat Doppler, and then terminate, right? So, you want to give a chance to the baby, give steroids and then terminate. On the other hand, the most fulminant is when it has become reversed. This is reversal of end diastolic flow. Timeline 32 weeks. More than 32 weeks, terminate. Less than 32 weeks, same concept. Give a fighting chance to the baby, give steroids and then terminate after repeating Doppler, right? So, this is what you are doing for IUGR. Uterine artery, remember we had studied the pathophysiology of PIH as lack of invasion of spiral artery by extravillous trophoblast. So, that's what's going to reflect into the uterine artery Doppler spectrum. So, this is what can predict early onset preeclampsia. So, that is what is a repeat question, that uterine artery Doppler can predict early onset preeclampsia. And lastly, middle cerebral artery we have studied in the context of anemia. Right, you can also remember in the context of IUGR, in both cases, we have the traditional brain sparing effect. In crisis, the baby protects the brain. So, paradoxically, nowhere we have blood, paradoxically, it increases in the brain. So, we have studied the middle cerebral artery, peak systolic velocity is going to increase, right? So, this is what happens in middle cerebral artery. Alright. Now talking about modified Bishop score. So, this is what will assess the cervical ripening. Okay. So, this is what is going to assess whether the cervix is ripened and whether normal vaginal delivery is going to progress or not. So, you need to know everything about this score. So, we have Bishop and we have modified Bishop. So, I have given you modified Bishop. The original Bishop had effacement instead of length. So, I am going to teach you both. They can ask you either. Okay. So, it's pretty easy. Dilatation, see this, 0, 1, 2 and 3 are the scorings, okay. So, you just have to remember less than 1, 2, 2 ka double 4, 3 numbers I need to remember, 1, 2 and 4. So, less than 1, 1 to 2, 2 to 4, more than 4. Now, make it opposite. So, length is inversely proportional to dilatation. So, this is 4, 2 to 4, 1 to 2, less than 1. So, this is sorted. If they give effacement, less than 30%, 0. 40 to 50%, 1, 60 to 70%, 2 and more than 80%, 3, right. So, this is how we are going to measure effacement. Station with respect to ischial spine. So, -3 matlab upper, -2, -1 to 0, below. So, this is station. Consistency, firm, average, soft. Position, PO, start with PO, posterior, mid, anterior, right. So, you need to remember this, everything calculation can be asked. Basically, anything more than equal to 6 means it's a ripe cervix and vaginal delivery will be possible, okay. So, let's talk a little bit about induction of labor. So, what do you do for induction of labor or basically augmenting labor? Dinoproston is the drug of choice. What is dinoproston? As we said, this is dinner for 2. That's how you can remember, dinner for 2, PGE2. Misoprostol can also be used. This is PGE1. You can also use mifepristone. You can also use oxytocin, oropholis or stripping of membranes. When you strip the membranes, this releases local prostaglandin. So, local release of prostaglandin is increased. When will you not induce? Very important table here, contraindications to induction of labor, essentially telling us indications of LSCS, right? So, indications of LSCS, obviously contracted pelvis or cephalopelvic disproportion, and this you have to remember anytime they mention molding or caput, right? So, molding, caput, 2 plus, 3 plus, you have to do LSCS. Placenta previa, as we said, normal vaginal delivery contraindicated. Previous classical cesarean, you will not do induction of labor, high risk of rupture. Post VVF repair, you will not do. Active herpetic ulcers, and I can also say active viral warts because this will predispose to the child having papillomatosis or HSV, CA cervix. Malpresentations, we will see the categories. Cord prolapse, always LSCS. Vasa previa, always LSCS, right? So, this is a good summary of everywhere where you have to do cesarean section. Now talking about fetal monitoring. So this is where we'll combine both intrapartum and antepartum fetal monitoring. So let's say a woman comes to you that my fetal movements are decreasing, right? A pregnant woman beyond 32 weeks is advised to do her daily fetal movement count. Let's say she comes to you that it's decreased. What is the next step? Next step is what we see here is non-stress test. So anytime daily fetal movement count is decreased, the next step is non-stress test. Non-stress test and cardiotocography are essentially the same instrument. Both are seeing the fetal heart, right? So it's like a fetal ECG that we are taking. If you do it antepartum before labor, this is NST. If you are doing it along the time of labor, along with labor, that's cardiotocography, because now you have two components. You can see this, right? So you are having the fetal monitor as well, and you are also giving this to the mother that whenever you have a contraction, you got to press it. So this is where CTG is both. It is cardio as well as tocography, which is comparing the maternal contractions with the fetal heart rate. Okay, so this is just the same machine, two different interpretations. This is intrapartum surveillance, this is antepartum surveillance. In both of the things, we have to see the same things, which is the reassuring pattern. What is reassuring pattern? That the fetal heart rate is normal. Normal fetal heart rate is 110 to 160 beats per minute. Then you have to see accelerations. What is a reactive NST? So reactive NST is normal fetal heart rate. There should be some beat to beat variability, all right, and there should be accelerations which are 2 or more acceleration lasting at least 15 seconds with a rise of 15 beats per minute. So this is more than 15 beats per minute for more than 15 seconds, 2 such accelerations within 20 minutes, right? So one NST is for 20 minutes and there should be no decelerations. This is where I am talking about NST, okay? When we talk about CTG, I'll talk about deceleration with respect to maternal contractions. Here, there should be no decelerations. All right. So, what all do you want? You want a beat-to-beat variability, which is around 5 to 15 beats per minute. So, there should be a variation, but it should be in the normal range as you can see here, and there are 2 such accelerations within 20 minutes. So, what do you do if the NST is non-reactive? So, if the NST is non-reactive, you repeat NST. You are going to repeat NST. So, in total 40 minutes, right? So, one NST is 20 minutes. Next NST is 20 minutes. So, in 40 minutes also, if you don't have an acceleration, if you don't have 2 or more accelerations, now you have to go for biophysical profile. All right, what is now preferred is a modified biophysical profile. Modified BPP includes NST, which you have already done. So, essentially just monitoring the amniotic fluid index. Okay, so now let's talk about the main BPP, complete BPP, which is also called as the Manning score. Okay, so what does it encompass? So, we already said reactive fetal heart rate matlab NST. So, 2 or more accelerations, 15 beats per minute of at least 15 seconds, right? So, that's reactive. A5 normal is 10 to 20. So, 5 to 25 was for your oligopoly diagnosis. Here, 10 to 20 is your normal range. Then you have TBM, tubercular meningitis, TBM. So, tone matlab at least one episode of active extension with return to flexion of limbs or trunk. Breathing, at least 1 episode in 30 minutes. Movement, at least 3 discrete body movements. So 1, 1 and 3. So this complete expanded BPP or Manning score is for 30 minutes, right? So this is what is your antepartum fetal surveillance. If you find this to be abnormal, then we will decide to do urgent delivery. Now let's talk about intrapartum. Intrapartum, this is what is your cardiotocography, where you are correlating the mother's uterine contraction with the fetal heart decelerations. So here what you want to remember, that the peak of the contraction coincides with the depth or the nadir of the deceleration. This is what is early decelerations. These are benign decelerations, likely because of the contraction. So here you don't have to do anything. You'll give IV fluids, you'll ask mother to go into left lateral decubitus if she is not, but these can be dismissed. You don't have to worry about it. So this is fetal head compression. What you do have to worry about are these. These are late decelerations. This is where the nadir is just after the contraction. This indicates uteroplacental insufficiency. So this is where, remember, late ho gaya, late uteroplacental insufficiency. On the other hand, this is where you have to do urgent delivery. And what do you see here? This is variable, no relation between contraction and the deceleration. Variable is because of cord compression. Alright, so you got to find out the cause of the same. And look at this one. This is where the fetal heart rate is sinusoidal. So this is a sinusoidal waveform, and that is a poor prognostic factor. It indicates fetal anemia. Very routinely you have to rule out vasa previa. This indicates vasa previa. Alright, so this is about the decelerations. Alright, so now let's start to talk about pelvic diameter. So what you can see here is the pelvic inlet. So this is starting from S1. Then you have S2. So this is where you want to remember is the plane of greatest pelvic dimension. This is passing through the S2, S3. Alright, so this is passing through S2, S3. So every one sacrum will give you one question. Means inlet via S1, greatest pelvic dimension S2, S3. What about S3, S4? This is what corresponds to mid pelvis. So mid pelvis is S3, S4, and at the level of S4, S5, this is where you have the plane of least pelvic dimension, and this is what passes through the level of ischial spines. Alright, so this is very, very important. This is passing through the level of ischial spine, and then you have the anatomical outlet passing through coccyx. So this is at the level of coccyx. Now let's talk about inlet. Alright, so at inlet there are three main things you want to remember. First is the true conjugate. True conjugate matlab upper pubic symphysis. Then you have through the mid portion, that's obstetric conjugate, and then through the inferior most part is the diagonal conjugate. So how you want to remember this is from up to down you have TOD, okay, T true, obstetric, and D for diagonal. Alright, so these are your three conjugates. You need to know their values. This is 11 centimeter, 10 centimeter, 12 centimeter. Alright, so obstetric conjugate is your 10 centimeter, and that is what you also want to remember is your least pelvic dimension, 10 centimeter. Anatomical outlet corresponds to ischial tuberosities. Okay, so this is where students get confused. Least pelvic is ischial spine. This is where all of your cardinal movements are happening. Remember? FIR, crowning, all of this was at the level of ischial spine. Okay, so this is about pelvic diameters. Fetal skull diameters, also few things that are important here. So first of all, let's understand the naming. So you know glabella is your frontonasal aspect ka external part, that's glabella. This is anterior fontanelle, this is posterior fontanelle. So between anterior and posterior fontanelle is the vertex. This is called sinciput, this is called occiput. Okay, so that's how the naming will be. So what is the shortest diameter is suboccipitobregmatic. So what is bregma here? Bregma is the anterior fontanelle. Okay, so this is what is your suboccipitobregmatic suboccipitobregmatic. This diameter here will only come when there is completely flexed head. So this is the shortest diameter. This is what you want to remember. That is when the attitude is complete flexion with vertex presentation. So when I say presentation, this is vertex. When I say attitude, complete flexion, and this is the corresponding diameter. As the complete flexion starts to become extension, the diameter keeps increasing. Incomplete mein aa jayega suboccipitofrontal. So now instead of bregma, now we come somewhere anterior. So it increases. More extension. Now what's going to happen? You have mentovertical. Look at mentovertical. This is mentum. Mentovertical will be in brow presentation, and submentobregmatic. Submento means iske bhi niche with bregma. This is for face. This is complete extension. So look at the beauty of this. When it becomes completely extended, that's also good, because again the shortest comes, that is submentobregmatic, that is face presentation. But when you are brow presentation, this is maximum diameter. This is where we have to go for LSES. Alright, so this is about the fetal skull. Just remember 9.5 SOB is most common, SMB is for face presentation. How we name the position, I am sure you know this. So this is where just look out for occiput. How to recognize? You all know that this diamond is anterior fontanelle, triangle is posterior. So wherever the triangle posterior fontanelle is, that's where occiput is. So always name it with the triangle posterior fontanelle. So what is the most common position? Is left occipitotransverse. So just imagine this is right, this is left. This is just like radiology. Okay, so right and left. So this is where you can see that occiput is on the left side. This is early in the labor, just before delivery, this becomes left occipito anterior and then occipito anterior. As far as OP is concerned, the most common occipito-posterior position is right occipito-posterior. So you can appreciate this is right side, this is where the triangle is, but posteriorly. So what we notice here is that this is going to take longer, isn't it? Earlier I had to move 2/8 of a circle, now you are going to have to move 3/8 of a circle. So this is just going to take a bit more longer, but it will move. So this is just where in OP you have to remember, you have to wait a little longer. Alright, so now let's talk about very important in recent times, the different types of pelvis. So gynecoid is your round pelvis, platyploid is your flat or oval pelvis, android heart-shaped pelvis, and anthropoid is where AP is more than transverse. So first step is to recognize these types of pelvis, right? Who is the most common out of these? Obviously gynecoid. Least common is platyploid. Where is AP greater than transverse? Anthropoid. And where do you have face to pubis delivery more commonly? Again, anthropoid. Deep transverse arrest ka maximum risk is with android, right? It's android, not meant to deliver. So that's where you will have deep transverse arrest. They will describe in the question that the pregnancy is not progressing, there is molding which is present. Think of deep transverse arrest. This has been asked. As far as occipito-posterior position is concerned, they are going to give you these hints like infra-umbilical flattening and fetal heart sounds are heard in the flank. Think of OP position. So this is occipito-posterior position. It is common in both anthropoid as well as android. Okay, so anthropoid and android can have OP position. What you want to remember, android will have the most common wala OP position, that is ROP, whereas in anthropoid you will have direct OP or persistent occipito-posterior in anthropoid. One more thing about platyploid, this is where you will have brow position. Okay, so platyploid associated with brow position. So these are things you need to know. As I said, occipito-posterior, nothing needs to be done. You just do wait and watch. It will progress. Alright, it will take a little longer. Extremely important, they'll describe there is a bag of worms, felt, cord, prolapse. What will you do next? Don't put it back. I told you in the beginning, in Obg2, instincts don't work. Your instinct will be like, what's the problem? Put it back. don't put it back. So what you have to remember that we never touch the cord, because as soon as you touch the cord, there can be risk of vasospasm. So all you have to do, the only thing that can be done now is LSCS. So you have to prepare for LSCS, but while you do it, change the position to Treadle-Lundberg position. So if both are in the option, this is rapid, right? So put the position first and then go prepare for LSCS. If you want to touch something, touch the head. Whatever is the presenting part, lift it off so that the pressure can be relieved of the cord, right? So this is the management of cord prolapse. A little bit about breech delivery. So in breech, what you want to remember that there are these three types here. So this is what is the most common one. This is frank breech. This is what is complete breech, where you can also see that the knee is also flexed along with the hip, whereas here the knee is extended, and this is where now the foot is out. So this is what is your foot-link presentation. This is the order in which you see breech delivery. Breech delivery, you can do normal vaginal delivery, but you try and do an external cephalic version. So what are the indications of external cephalic version? So this is what I am teaching you in one line, the complete chapter. So more than 36 weeks, you will do this. This is in singleton only who have breech or transverse which are not in knee or foot-link presentation. So breech or transverse singleton, adequate liquor, membranes intact, normal fetal heart rate, no placenta previa, because placenta previa anyways you have to do cesarean section, right? So these are all the indications, and if you remember this, even contraindications get covered. So this is where you will do external cephalic version. If one attempt is not successful, you can repeat one more after 1 week. If not successful, then you have to go for cesarean section. This is done in labor room itself, okay? But what here you have is internal podalic version. This is done if the second twin is in the transverse lie and there is no previous LSCS. So then you can give a trial of internal podalic version, okay? This is done in the OT under anesthesia, okay? Look at a few maneuvers. They give you questions from this. One came in the last NEET exam as well. So what is this one here? This is where you are trying to rotate. How I remember this is offsetting. Alright. So you are trying to offset. So all of these are for breech after coming of head methods. So this is Lawset maneuver. Next, what you are seeing is you are applying suprapubic pressure and then you are lifting the baby. Here you are using the baby's own weight. Okay, so this is most important, Burns and Marshall method. So this is what is Burns and Marshall, where you are going to use the baby's own weight to swing the baby. Next, here you can see one hand on the nose, right? When will you cover the nose? When it's very smelly. So this is what is your smelly method. Okay, so it is actually 3 words, smelly, Morris, V, but you can just remember smelly method here. Next, they can ask you about these forceps. So these are Piper forceps. Ignore the image because it's not even after coming of head. So Piper is after coming of head. Alright, so just want to remember that these are Piper forceps. So now let's start with oncology. Here I'm going to teach you the stagings, but I don't know if they'll be asked. They have asked CA cervix a couple of times. Apart from that, CA ovary also has been asked once, but you know, not very important that you have to revise on the last day, but do give it a look once at least, okay? So we're starting off with the most important, that's carcinoma cervix. First, I'll talk about screening, which is very important. A few things about HPV. You know, human papilloma virus, there are low risk strains and high risk strains. Low risk strains we have studied with viral warts, right? So they are the ones that are going to cause condyloma acuminata. Where did we study condyloma lata? That was syphilis, right? So this is condyloma acuminata. This is HPV 611, whereas high risk HPV is 16, 18, 31 and 33, and 3 more strains. So you have 45, 52, 58. What you want to remember? A trick. You remember the first 4, 16, 18, 31, 33. Here, take out 5 and then you have 4 twos are 8. Alright, so that's a good way to remember these strains. So this is about HPV. Why we need to remember all of these is these are total of 9 strains, right? 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 strains are what are included in Gardasil 9. Sarvavac is the Indian vaccine, right? So this is where you only have the top 4, that is 6, 11, 16, 18. So this is your quadrivalent vaccine, whereas Gardasil 9 has all of these strains. Important thing about HPV, L1 is the protein from the genome that is used for vaccine. E6 inhibits P53, so 6 को उल्टा करेंगे P53 inhibition, whereas E7 inhibits RB, right? So that's what the mechanism is. Talking about vaccination protocol, so important is WHO SAGE protocol. So this is where our primary target is 9 to 14 years, right? So not just girls, girls and boys both. 9 to 14 years, you want to give them either 1 or 2 dose, okay? So either 1 or 2 dose, this is your primary target. If not, 14 to 21 years, again 1 or 2 doses of the vaccine, but more than 21 years, now you got to give them 2 doses 6 months apart, right? So this is what is the vaccination regimen. Now let's talk about pap smear. So screening of CS cervix is with pap smear. This is a cancer of the young, unlike endometrium and ovary which occur in postmenopausal women. Ovary obviously has different types, so different age groups, but endometrium particularly happens in elderly postmenopausal women, right? So you have to start pap smear at 21 years. You have to do it 3 yearly. But if you are doing co-testing matlab pap smear plus HPV DNA testing, then you can do it 5 yearly. But you must start HPV DNA testing only after 30 years because then you would have a lot of false positives otherwise, okay? So most women have HPV at the onset of sexual activity and then they clear it off, right? So if you screen less than 30 years with that, there might be a lot of false positives. So you want to only start testing HPV DNA after 30 years. In immunocompromised, because there's higher risk, you know, the risk of CS cervix increases with early onset of sexual activity. You will have more sexual partners, so higher risk with HIV AIDS. So these are the risk factors. So if you're already immunocompromised, there is a higher risk. So here the screening is more frequent, that is annually. When do you stop the screening? So you stop the screening by 65 years, provided there is 10 years of negative data, meaning either your last 3 pap smears were negative or your last 2 co-testing were negative, right? So basically 10 years of negative data has to back it up. Then very, very important, you have this seems like a very potential question to me. So by 2030, WHO has laid down these targets. 90% of girls should be vaccinated by 15 years, okay? So our target group of 9 to 14 years, we want 90% of those to be vaccinated by 15 years. 70% screening. So we start with primary prevention, that's vaccine. Secondary prevention, early detection is screening. So that's pap smear. So we want 70% women to be screened in between 35 to 45 years age group and 90% treatment, right? So this is just like PSM, primary prevention, secondary early detection, secondary treatment. That's how you remember 90, 70, 90. We want 90% women with CS cervix to have received treatment, okay? When we talk about pap smear, so this is what is your conventional pap smear. This is what was done previously, or it's still done in, you know, government setup. So this is conventional pap smear where you can see this wooden IR spatula and then there is this cervical brush. So what you're going to do is you're going to place this. So look at this. Imagine harder that this is cervix, all right, and this is endo and ectocervix, okay? So basically the maximum risk of CS cervix is here. This is the transformation zone where the columnar epithelium then becomes stratified squamous. This is what we have learnt in ANAT, right? So that is where maximum risk of cancer is. So what you have to do is, this is how your IR spatula is placed at the transformation zone and you take a circular swab and then you put your brush inside and take sample from the endocervix. So this is what is Ayer's spatula cervical brush, and then you make a slide out of it. The fixative that you're going to use is 95% alcohol, and this is the pap stain. So multiple times this has been asked in INICT particularly. What are the components of pap stain? So eosin Y, orange G6, hematoxylin and light green SF. So this is something that you need to memorize. So these are components. Now what we have replaced it with in most setups is liquid based cytology. This is far more sensitive than a pap smear. So here what you have is a single instrument. So this is what is your cervical broom or your cervical brush. Right? So this is what is the single instrument. If you see the shape now, can you visualize? This is the part that goes inside and this takes the sample from transformation zone. So only one device very quickly you can move, and then you cut it from here and you put it in the liquid. No need to make a slide. That's where your results go wrong if the slides are not made properly. And you know how great slides we used to make, right? You don't want that. You remove the human component here. I mean, human component is still there, but you remove the slide making here and you put the brush inside into this liquid medium. This comes as Thin Prep and Sure Path. Those are two company names. The only difference here is that the fixative is now not ethyl alcohol, but it's methanol. Okay, just extra point. So this is liquid based cytology that you want to know about. So this is Thin Prep, Sure Path, two names, which increases the accuracy. Right, a little bit extra that I want to teach you here. So let's say you did a pap smear. Okay, now what do you do next? So the pap smear will give you the result in, low risk, high risk. There are variety of results. So basically what is significant is L-cell and H-cell, low grade and high grade squamous intraepithelial lesion. Apart from that, you may get ascus, which is atypical squamous cell of undetermined significance, or you may get atypical glandular cell. Let's just focus on this here, which is definitely abnormal. Ascus, you don't want to go into the details. Atypical glandular cells, you want to follow it up with an endocervical curettage next, because this represents that there are some endometrial cells which are abnormal. So now we want to sample that. So this is different. Let's come back to pap smear showing abnormal results. What do you want to do next? Next, what you are going to do is a colposcopic biopsy. Okay, so colposcopy is nothing but a microscope for the vagina and basically the cervix, and that is where you will see the abnormal areas which look as abnormal vascular patterns, and those are the areas you're gonna sample. Upon doing the biopsy, now you get to see the invasion. So if it is restricted by the basement membrane, that is what is carcinoma in situ. So it can be CIN1, or it could be CIN2 or 3, or it could be invasive cancer. If it is invasive cancer, we are going to learn the management staging separately. If it is carcinoma in situ 1, you are going to do a surveillance. You follow up this patient for 2 years. You will sample them annually. If it stays the same, in that case, you have to do cryotherapy. If it doesn't resolve, 80% patients will resolve here. If it still remains the same, cryotherapy. But if it is CIN2 or 3, then you are going to do an OPD procedure called LEAP or LETS, which is essentially like a razor loop electrosurgical excision. You are basically shaving out that transformation zone using a cautery, right? So that's a dummy version of explaining you LEAP. Okay, so again, an OPD based procedure doesn't result in bleeding. So this is what you have to do for CIN2 and 3. Where would you do conization? So conization is done when there is any discrepancy. Conization means you are now taking a bigger tissue, a cone of tissue at the transformation zone. So conization will be done if there is any discrepancy between the pap smear and colposcopy result, or you have micro-invasive cancers. So these are two indications. There are many indications, but two which could be tested. Alright, so this is what you want to remember as far as screening protocol and the rest of it goes. Apart from this, what you also want to remember here is, what if there is already a mass? If there is postcoital bleed, you are going to do the same thing. It's just bleed, you are going to do a per speculum examination. And if there is no lesion, same, pap smear followed by colposcopy. But if you see some sort of erosions, then what you have to do is directly go for colposcopic biopsy. So if already the patient is symptomatic with a mass, so if there is postcoital bleed plus a mass, then you will directly do a 4-quadrant biopsy here. If there is an erosion, you can do a colposcopic biopsy depending on how big the lesion is, but you directly can biopsy it. So this is what you need to remember. If you are at a resource poor setting, then you can go ahead with VIA or VILI. This is where you are directly visualizing visual inspection with acetic acid and visual inspection with Lugol's iodine. In acetic acid, the abnormal areas are going to stain. Aceto-white areas is what you target, whereas in Lugol's iodine, you target the areas which are not stained. That's the concept here. So with this, now we venture into the staging. So when we talk about CA cervix staging, you have to memorize. But one thing I can help you with here is, this is a woman who is from South Africa. And she is the vice president of a firm in Connaught Place. Okay, so right now forget her race. She is a vice president at CP. What to do with this? We'll come back to it. First, the staging. So stage 1A is a microscopic stage where the stromal invasion is less than 3 mm or 3 mm to 5 mm. 1B basically is invasive, the size being less than 2 to 4, more than 4. 2 is where now it's going into vagina, that's 2A. 2B is parametrium but not pelvic wall. So this is VP, vagina parametrium. Same VP you are now going to use. So 3A is lower 1/3 of vagina. 3B is pelvic wall, and pelvic wall is what includes the ureter. So this is hydronephrosis. This is what is most commonly asked because uremia is the most common cause of death in patients with CA cervix. That's because of compression of the ureter. And you want to remember VP was from CP. So 3C1 and C2 are pelvic paraaortic lymph nodes. So how to remember? 1A was microscopy, 1B is clinically visible, 2A, 2B, 3A, 3B. Remember as VP. That was upper 2/3, now it is lower 1/3. This was parametrium, this is pelvic wall, and then you have CP. So this way you will remember 4A adjacent organs, 4B distant organs, and this is what also includes inguinal lymph node metastasis. Inguinal lymph nodes will be distant metastasis. Okay, so that's very, very important. Now the management. First of all, till when can we do a fertility preserving surgery or a uterus preserving surgery? That is till stage 1B1. So whatever I am highlighting now, your 1A and 1B1, invasive cancer less than 2 cm, this is where I can do a radical trachelectomy. This is just removing the cervix without removing the uterus. Okay, so this is the point till which you can do. So I am going to write here till 1B1. Then the management. So what you have to remember, here comes the importance of 4 cm. So till 1B2 and also 2A1, we are going to be doing surgery. So what all stages are amenable to surgical treatment? I can write 1A1 and 1A2 or just 1A in general. I can write 1B1 and 1B2, and we can remember 2A1. How I remember is this: anything which is less than 4 cm we can do. Anything which reaches beyond 4 cm you can't. Beyond this stage, what are you going to do? Beyond this stage, just chemo radio. Alright, so this is the indication of surgery. The surgery that you are going to do here is going to be your radical hysterectomy that I am going to come to. So now let's talk about the types of hysterectomies. So this is what is your simple hysterectomy, also called as extrafacial hysterectomy, where you are just removing the uterus and everything is ligated close to the uterus. This is what is modified radical hysterectomy, also called as Wertheim's hysterectomy, where you are ligating midway at the level of ureter. On the other hand, what is radical, where you're removing everything, this is also called as Meigs hysterectomy. Lateral to ureter, near origin of internal iliac, near rectum. So this is what you need to know about the types of hysterectomy, about the radiotherapy port. So as you remember, radiotherapy in cervix is brachytherapy. You go close to the cervix and give the radioisotopes. So 2 points you want to remember, point A and point B. Both of these are 2 centimeters from the external os, 2 centimeter above the external os. This is 2 centimeter from the midline, while this is 5 centimeters from the midline. At point A, you give a higher dose of 8 gray, whereas B is 6 gray, right? So centigrade also you can remember, 8 gray and 6 gray is what you want to remember here. Now, let's talk about CA endometrium. So, here the staging not extremely important, but you can remember it. 1 means it is confined to uterus, less than 50% invasion, more than 50% invasion. 2 means it is going into cervical stroma. The gland involvement is not counted, only stroma. Now, you will remember our vice president working in CP coming from South Africa. So, 3A South Africa, serosa adnexa. 3B, vice president, vagina, parametrial involvement. C being same, pelvic, para-aortic. 4 is anything which is distant mets. So, you have bowel bladder, distant mets, inguinal lymph node. Same thing as CA cervix, counted as distant metastasis. Here the management is simple. You are going to do TAH plus BSO for treatment, and you will give radiotherapy, which is adjuvant radiotherapy if there are any high risk features. So, what are the high risk features which are counted? So, whether you have any lymphovascular space invasion, lymph node positivity, or any other high grade, right? So, any grade more than 2, you will give adjuvant radiotherapy. Okay, decided on a case to case basis. This is the new FIGO staging which has come last year itself, 2023, which is very complicated, too complicated to even read. Okay, so I don't think you'll get a question, but you just want to remember that it includes these mutations. So P53 mutation, pole mutation, these are given special subtypes. Okay, so you can just give this a read if you want to for an extra edge. When we are talking about endometrial cancers and the mutations, a few things that you want to remember, that there are 2 types. Okay, so there is type 1 versus type 2 endometrial carcinoma. Type 1 has a good prognosis, whereas type 2 has a bad prognosis. Type 1 is associated with KRAS and P10 mutations, whereas type 2 is the one associated with P53. Type 1 is your endometrioid subtype, whereas type 2 and 3 or type 2 is essentially your papillary/serous subtype. Okay, so these are a few points about the histology. Another thing about C endometrium is that you are going to have endometrial hyperplasia as a risk factor. So, endometrial hyperplasia is any endometrial thickness in a postmenopausal woman which is more than equal to 4 mm. So, thickened endometrium more than equal to 4 mm. This is an indication of endometrial biopsy. So, upon biopsy, if the diagnosis comes out as hyperplasia, a few numbers I want to teach you. There can be 4 types here. So, there can be simple hyperplasia without atypia or with atypia, or there could be complex hyperplasia without atypia, with atypia. 4 numbers for you, 1, 3, 8 and 29. So, this is 1%, complex without atypia 3%, simple with atypia 8%, 29%. So, 1, 3, 8 and 29, 4 numbers. If this comes, I'll take a party. Okay, so this is about the hyperplasia. When we talk about the management, so here we don't need all 4. Anything without atypia, you can just treat her with progesterone, which could be either Mirena, or you can give her medroxyprogesterone acetate. If there is atypia, it's best to do a hysterectomy. So, a simple hysterectomy or extrafacial hysterectomy will suffice here. Okay. So, this is about endometrial hyperplasia. Now, talking about CA ovary, this is where the path aspect that I'm going to teach you is actually more important than the staging, but just to get through it. So, Stage 1 is where it's limited to one ovary or tube or both ovaries or fallopian tube. If there is any spill outside, matlab capsule is not intact. So either surgical spill or capsule ruptured or cells in the ascites or peritoneal washing, it becomes 1C. 2A is where it is still in the pelvis, but now it's gone into uterus, ovary or fallopian tube, matlab the other ovary. This is you have other pelvic tissues. And 3 matlab now you have gone into peritoneum. So 3A is RP lymph nodes but positive only on cytology or histology. Peritoneal mets less than 2 cm, peritoneal mets more than 2 cm, or capsule of liver and spleen. 4A is pleural effusion, 4B is distant metastasis in the parenchyma, and again inguinal remain 4B. So this is what you need to remember here. The management is simple. It's always a surgical staging. Alright, so you will do the surgery which is going to be TAH plus BSO, and you are going to take samples from different sites, and this is what is called as debulking surgery. So you're going to take samples and try to remove as much cancer as possible. In stage 1A and 1B, only this much is enough. Anything else you have to then follow it up with adjuvant chemotherapy, which is a BEP regimen, bleomycin, etoposide, platinum compounds, right? So this is about CA ovary. Going to the most important part, that is the path aspect of CA ovary. So here what you want to remember, there are 3 types, okay? So the first one are your epithelial categories. In epithelial, the most common one, I am sure you know, within epithelial is the serous type, right? So here the most common type is the serous cancer. Here you may also see psammoma bodies, okay? So that's one thing you would have known. Pseudomyxoma peritonei is spread into the peritoneum, which is going to have mass effect. So this is where you will have scalloping of the liver surface, spleen surface. This is associated with mucinous cancers. So this is a finding you see in 2 places, mucinous adenoCA of ovary and mucinous adenoCA of the appendix, right? So here mucinous ovary. Volthard cell rest, you want to remember, is a feature of transitional cell type, and this is what we call as the Brenner's tumor. So you can remember Brenner means your behen. You have a transitional relation with your sister. Sometimes it's good, sometimes it's pathetic. So this is what is transitional cell, and imagine you are having a coffee with your sister sitting on the wall. So this is Volthard, and what is the coffee? That is the coffee bean nucleus here. So this is about epithelial. Going on to next category, that is germ cell tumor. Overall most common is a mature teratoma, also called as a dermoid cyst, and I have shown you this in radiology where you will see fat, you will see tooth, right? So that's mature teratoma. Most common malignant germ cell tumor is a dysgerminoma, the counterpart of seminoma. Tumor markers, we already know with respect to testicular tumors. So AFP is always yolk sac tumor. Yolk sac tumor equals endodermal sinus tumor. And what do you see here? You see this glomeruloid body, a central vessel and then cells. This is what is called as a Schiller-Duval body. So Schiller-Duval body seen in your yolk sac tumor, endodermal sinus tumor. HCG, as you know, is a marker of choriocarcinoma. Choriocarcinomas are going to show you these elongated cells which are nothing but trophoblasts, syncytial trophoblasts, which produce, remember, syncytial trophoblasts were the ones producing beta HCG. They are still producing beta HCG. CD30 is embryonal cancers. LDH, PLAP, HCG, OBG2 and NANOG. Extremely important, long list is for dysgerminoma. So can I say all of these are also the markers of seminoma? Yes. And this still remains a small round blue cell tumor like seminoma. Talking about the third category, which is sex cord stromal tumor. So here, sex cord, this is what are going to produce hormones. So they can either be estrogenic or virilizing. Estrogenic sex cord stromal tumor, you want to remember, is going to be granulosa cell tumor, and that is the one granulosa. Remember your follicle, right? That is going to produce the estrogen and inhibin B. So inhibin B is the marker of granulosa cell tumor. You're also going to see these bodies. You can see this follicular sort of an appearance of the granulosa cell. These are what are your Call, Exner bodies, and Fox is also mnemonic. So you can remember Call, Foxy, Granny. Okay, so this is granulosa cell tumor. Because this is estrogenic, this can present with postmenopausal bleed or precocious puberty. Very, very important. Whereas virilizing sex cord tumor, this is what is called as an arhenoblastoma. Okay, so this can arise from your Sertoli Leydig cell. So Sertoli Leydig cell, arhenoblastoma, these are your virilizing tumor. And when you have a pure Leydig cell tumor, you're going to see these Renke crystalloids. This was asked in INICET, these pink structures here. These are seen in Leydig cell tumors. Okay, and lastly, Meag's syndrome is seen in your stromal tumor. So Meag is usually your fibroma thecoma complex. Okay, so fibromas usually show Meag's syndrome, which is a triad of a solid ovarian tumor with pleural effusion and ascites. Okay, once you remove the ovarian tumor, the other two resolve on their own. So that is what is the important part here. So now the last cancer, that is CA vulva. This is particularly asked in AIIMS and INICET, right? So this is what will present as this irregular mass on the introitus. If you see this, there's this specific forceps that is called as Keyes punch biopsy forceps that you can use for the biopsy. What you need to remember here, that this is the only one where the sentinel lymph node is going to be inguinal, right? Everywhere else we saw inguinal lymph node. For all other cancers was the distant spread, 4B. This is the only type where it's the first lymph node to be affected. We have already seen this in urology as well, that CA penis, distal anal canal and CA vulva are where you are going to have inguinal lymph nodes as the sentinel lymph node. So this goes on to the superficial inguinal lymph node, and from that it can go to deep inguinal, from there it can go to iliac. Okay, so the sentinel remains superficial inguinal. Now the staging here, not very, very complicated. What you need to remember, that we also take into account the stromal invasion. If stromal invasion is less and lesions are 2 centimeter or lesser, this is where you can just do a wide local excision. Low stromal invasion relates to the fact that the risk of lymph node is low. Next, when you see that the lesion is more than 2 centimeter or stromal invasion is more than 1, this is where lymph node spread is likely. So this is where now you are going to do wide local excision plus ipsilateral lymph node dissection. But the movement it goes to lower 1/3 urethra, vagina, anal canal, now you have to do radical surgery. This is where you will do radical vulvectomy, alright, which also includes bilateral lymph node dissection. Beyond this point, whatever it is, any stage which is ahead of this, you now have to give CTRT, right? So then the treatment becomes palliative. So the simple management of CA vulva stage wise. Now talking about prolapse. So extremely important, first of all, supports of the prolapse. So you have true ligamentous supports which include uterosacral ligament. This is the most important. McEnroth's, which is cardinal or transverse cervical. This is where we saw the uterine artery and ureters running. True muscular supports include the pelvic diaphragm. If you remember, pelvic diaphragm has all 3 parts, right? Pubococcygeus, iliococcygeus and ischio-coccygeus, whereas your levator ani is these two, pubo and ilio. Urogenital diaphragm and perineal body. This was the older staging of prolapse, where with respect to the introitus, you would see where the vagina is. The latest staging which has been asked in the recent exams is your POP-Q staging, for which I got no party even though I told you. So this is POP-Q staging. This is where the reference is hymen. That is all that you need to remember. Most important question is from the surgeries of prolapse, right? So first of all, Anybody who is pregnant or extreme elderly where you don't really want to operate, this is where you are going to use a ring pessary. So pregnant or immediate postpartum, use a ring pessary. If there is somebody who is a poor surgical candidate, in that case you want to do an obliterative procedure. So basically this is where you are closing the vaginal opening. This is Lefort colpoclysis. The ideal procedure is reconstructive procedure, which is called as Ward Mayo, where you are repairing the anterior and the posterior floor. So if they give you cystocele matlab bladder herniation anteriorly. So for cystocele, the management is anterior colporrhaphy. Here you are going to strengthen the anterior floor. If they give you rectocele matlab posterior wall. So this is colpoperineorrhaphy. So in reconstructive, you are doing both of these and also removing the uterus. So this is hysterectomy. But if they ask you what about vault? So for vault procedures, what you want to remember is you are going to fix the vault, and that is what is called as sacrocolpopexy, right? So that is what you are going to do. I've also written something here for enterocele. Remember, we do McCall's caldoplasty. Coming back to vault, the treatment of choice is sacrocolpopexy. What you can also do is a suspension. So what you can do is a uterosacral suspension or a sacrospinous suspension. So this is what can be done here for vault. Okay. So this is vault procedures. Now talking about fertility preserving procedures. So fertility preserving are your sling surgery. So as we were discussing, this is where you are fixing the cervix to sacrum, rectus sheath or ASIS. So these are your suspension procedures. For sling procedures, Shirodkar, Purandri or Khanna procedures, these are going to preserve the fertility. Whereas uterus preserving, not fertility preserving. So these are cervical amputation procedures which have two indications. One is if the uterocervical length is more than 12 centimeter and family is complete or fertility is not desired. This is where you will do Fothergill, same as Manchester repair. So loads of names here. If this was not enough, more names coming your way. So we have stress urinary incontinence. This is where they'll tell you a woman who's had a lot of babies, poor strength of the pelvic floor, and this happens because of urethra being hypermobile. So this is because of urethral hypermobility. And they will give you the history, stress incontinence. They'll give you history that there is incontinence or urine leak whenever a woman coughs or sneezes or does Valsalva. So only upon stress there is incontinence. The gold standard management is what is called as Birch-Colpo suspension. But what is done? So this is the gold standard, but what are commonly done are your TVT or TOT procedure. So this is what is a transobturator sling. So this image based question can come. So this is transobturator sling, or you can remember TVT, transvaginal tape. Alright, so these are your SUI procedures, okay, extremely important, all of this part here. Moving on to few hide points that we have to do. So first, let's talk about a few teratogens. This we have done all across various subjects. This is just combining them so that we can culminate here. Valproate phenytoin cause neural tube defects. ACE inhibitors, ARBs are contraindicated because they cause renal agenesis. Lithium, you all know, causes Epstein's anomaly, atrialization of the right ventricle. So this is Epstein anomaly. Misoprostol causes abortion, but if not, it is going to cause Mobius syndrome. Mobius syndrome is cranial nerve 6th and 7th involvement. Isotretinoin, we said, right, washout period 1 to 3 months, whereas acitretin was 3 years. This is what causes mental retardation, facial anomalies, essentially embryopathy. Okay. Alcohol, again, mental retardation, facial anomalies. The facial anomalies typical is going to be the mid-facial hypoplasia, and something specific is a smooth philtrum, right? So philtrum is this part below the nose that's smooth here. Warfarin, as we said, is going to cause epiphyseal dysgenesis. So this is what is called as chondrodysplasia punctata. Chondrodysplasia punctata is punctate epiphysis. Methotrexate, you want to remember, is clover leaf skull. Methimazole can cause choanal atresia and cutis aplasia. This is what we already studied, right, in surgery, that you will not give this in the first trimester. In the first trimester, you're going to give PTU, but PTU has high hepatotoxicity and agranulocytosis, so you can't give it beyond first trimester. In second and third, you will again switch to methimazole. This is for women who have Graves' disease, okay. Indomethacin is contraindicated more than 32 weeks, right? So everything we see is more dangerous in the first trimester. This one is more dangerous closer to delivery because this can cause PAH, right? It can cause premature closure of ductus arteriosus leading to PAH. Tetracycline is going to affect the bone and teeth. Thalidomide, you know, causes phocomelia, right? So this is phocomelia, this is flipper baby. Don't confuse this with amniotic band. In amniotic band, you will have complete dysgenesis. You will see a ring literally forming there. So this is phocomelia or a flipper limb baby. And sulfonamides, what they're going to do is they're going to fight with bilirubin for albumin. This also binds to albumin, okay. So this is what binds to albumin. So this can displace the bilirubin leading to kernicterus. So sulfonamides shouldn't be given near the term to a mother. So this is important. A few numbers. What are the caloric requirement that are to be increased? So here first trimester, no increase. Then remember 350. 450, but 0 to 6 months lactation is the maximum increase. So this is 600 and this is 520. Steroids, extremely important, as you remember, should be given anytime a pregnancy is going to deliver below 34 weeks for lung maturation. So this is going to decrease the risk of respiratory distress, necrotizing enterocolitis, IVH, remember we had studied germinal matrix hemorrhage, and overall neonatal mortality, but there is no change in neonatal jaundice. So protocols now. So the best drug here is beta-methasone. This is very, very nice to remember, okay. Whatever is in the name is what you have to bring and you have to somehow reach a product of 24. So beta-methasone is 12 mg 2 times because 12 2s are 24. So 12 mg 2 doses 24 hours apart. This is all intramuscular injection. Government of India uses dexamethasone. So in India we use dexa matlab 6. So 6 mg how many times to reach 24? 4 doses 12 hours apart. Okay. 2 random questions post VVF repair. First of all, VVF repair, just remember let's go repair. This is usually vesico-vaginal fistula that can happen post-obstructive labor. Sexual abstinence should be maintained for 3 months. Pregnancy should be avoided 1 year post-repair. Maximum amniotic fluid is around 34 weeks and the major contributor is fetal urine, right? So these are few questions here. Normal uterocervical length is 6 centimeters. Now, let's talk about perineal tears, okay. So first and second degree perineal tears, you want to remember, first degree is only vaginal mucosa, second degree is perineal muscles. What is episiotomy? Episiotomy is an iatrogenic second degree tear. Why don't we just give a first degree tear? It's because if this gets extended by mistake, now you're going to end up with third. So rather than that, it's better to give a mediolateral episiotomy, cut the muscles but prevent third degree or fourth degree injury. So third degree is where you have injury to the anal sphincter and fourth degree is rectal mucosa. First and second degree tear can be repaired in the labor room itself, whereas third and fourth have to be taken to OT. So with this we talk about episiotomy. So this is the episiotomy scissors. These are what are at an angle, right? So these are 60-degree angled scissors in order to give a mediolateral episiotomy cut. The timing is at the time of crowning. Don't give it before. It's at the time of crowning. And the order of cutting is alphabetical order. So you're going to start with mucosa, C, then S, muscle, and then skin. Okay. The repair is also in the same order. It is a second degree iatrogenic tear. They ask you which muscles are cut and which are not cut. So remember what are not cut. Smaller list. Obturator not cut, ischiocavernosus not cut, whereas bulbospongiosus, levator ani. Levator ani is your pubococcygis and iliococcygis, and transverse perenniae, they are cut. A little bit about instruments. So this was asked in this NEET exam as well. This is what is the flexion point where vacuum is placed, which is 2 cm anterior to the posterior fontanelle. Remember, vacuum is the only thing which can allow rotation, right? So this is the one that you will do. If the position is occipito-posterior, it can also rotate, whereas forceps can't rotate. So that is important. These are your outlet forceps, Wrigley's outlet forceps. For applying any sort of instrument, whether it is a vacuum, cup or forceps, what you have to ensure is there has to be full cervical dilatation. The dilatation must be more than 10 cm, and you have to ensure that the station is at least +2 or more, right? So it has to be at least 2 cm below the ischial spine, right? So this is what we need to know here. Just a few instruments that we use, followed by the termination timelines. So this one here is your Sims speculum. So this is what you have to hold, right? So Sims speculum, one person will have to hold and somebody will then have to retract the anterior vaginal wall. So this has to be used with this anterior vaginal wall retractor, whereas this one here is your self-retaining, right? So this is Cusco's self-retaining retractor. So this is what can be used for various things like, IUD insertion, pap smear, etc. So this is self-retaining. What you see here has these teeth here. So this is valsellum. So don't use this in a gravid uterus or cervix. So this is what is to hold the anterior lip of cervix, not in a gravid cervix. In that you can use your sponge holding forceps. These are your Hagar dilator. So this is for dilatation, right? Whenever you are doing DNC or DNE, you are going to dilate one by one, and the dilator you are going to use is going to be equivalent to POG. The dilator you are going to be using is going to be POG -1, right? The size which is POG -1, okay? This, as we have seen, is your manual vacuum aspirator, and what are these are your Karman cannulas. Karman cannula is the one that we are going to use for suction and evacuation. Karman cannula ka size is equal to the POG. That is the size you will insert. For DNE, we had learnt ovum forceps. So ovum forceps are going to be used for dilatation and evacuation. And whenever you are doing any MTP, at the end you are going to use this blunt curette, not the sharp curette. The blunt curette is what is used. So this is for dilatation and curettage, and you remember the completeness of curettage is going to be when you see a grating sensation. Alright, so this is blunt curette. So grating sensation, air bubbles coming out, no more products coming out. So all of these things are, signs that the curettage is complete. Then you have this myoma screw here. This is what is called as Bonney's myoma screw, whereas this is your Bonney's myomectomy clamp. So both of these are for myomas or myomectomies. So this is Bonney's screw, whereas this is your Bonney's clamp. Both of these instruments are for myomectomy. And this is what we have already studied, is your Leach-Wilkinson's cannula. This is what is used for HSG, hysterosalpingography. Last part here is compilation of the most important timelines. Essentially, the concept remains that if it is under control, go till 39 weeks. If not under control, terminate at term, right? So that is what we are going to be seeing. So just oligohydramnios, 39 weeks, but associated complication, 37. GDM controlled on diet, 39. Not controlled, 37. Mild preeclampsia, go till term, 37. But if it is severe, then till lung maturity, right? Eclampsia or help? Now you can't wait. Okay, impending eclampsia or eclampsia, immediate termination of pregnancy. Everybody gets labetalol. Eclampsia, help and severe preeclampsia also get magnesium sulfate. RH immunization not sensitized, same thing, 39 weeks, but if sensitized, 37 weeks. Placenta previa, what was the number? 37. If more than 37, go ahead, do an LSCS. If not, McAfee-Johnson. Abruptio 34, but this is where you will do induction of labor, right? So, more than 34 induce, less than 34 give steroid and then induce. Never give tocolytics, no role of tocolytics. This is also something you know.